comprehensive health care. We shall now invite for the director table, the director of Mrs. Rhonda Seeley Thomas. Also the Executive Secretary of the Ministry of Health of Brazil, Mr. Adriano Massuda. The Director of Human Development for Latin America and the Caribbean from the World Bank, Mr. Jaime Saavedra. The head of the Division of Health, Nutrition and Population from the Inter-American Development Bank, Mr. Javier Guzman. Representing the Mayor of Rio de Janeiro, the Municipal Secretary of Health, Mr. Daniel Sorans. As representative of the Getúlio Vargas Foundation, the Director of Research and Innovation, Mrs. Gorete Pereira Paulo. This event is being transmitted via the channels of DataSUS of the Ministry of Health and the Pan American Health Organization. We would like to thank all of you who are following us remotely. Now we are going to give the floor to the Director of Research and Innovation of the Getúlio Vargas Foundation, Mrs. Gorete Pereira Paulo. Good morning. Good morning, everyone. On behalf of the FGV, I would like to acknowledge my colleagues at the panel, the representative of the Pan American Organization of Health, Christian Morales, Mr. Adriano Massuda from Brazil, who is also a professor at our School of Administration, and I would like to acknowledge our Vice Director, the Director of Development for Latin America and the Caribbean from the World Bank, Mr. Saavedra, the Chief of the Population of the Inter-American Bank of Development, Mr. Javier Goodman, representing the Mayor of Rio de Janeiro, the Municipal Secretary of Health, Daniel Sorans, and all of you present in this meeting. It's an honor for me to have you here. This event is very important to Brazil. Healthcare is a major issue, and we are totally aligned with the mission of our institution to contribute to the socio-economical development of Brazil. There is no development without health, and Brazil has today a system that is a model for the whole world, the SUS, our Universal Health System. So to be here participating in the debates that we'll have today is critical for our strategy of contributing to the improvement and the continuous improvement of the policies of healthcare in Brazil. We have just started our National Center of Policies for Healthcare. It's yet another action to contribute to create public policies based on evidence, and we are going to evaluate those policies based on programs that are already ongoing, both in Brazil and all over the world. I'll give the floor to my colleagues, and I hope you have fruitful discussions during the day. Thank you for being here. Now I'd like to invite Mr. Daniel Sorans. Thank you. I would like to acknowledge Mr. Adriano Massuda, Mrs. Gorete, Mr. Javier, Jaime, thank you for choosing Rio as the place for this event. It's an honor for us to hold this event in our city. Within our system, the universal health system that we have, with a very small budget vis-a-vis the other countries of the world, we are able to implement the SUS, our universal healthcare system. We have difficulties in terms of financing, but the system is efficient and it works pretty well. We started in Rio on a late days. The Ministry of Health was recommending that we started primary health care, but we were late. We've been doing it for 15 years only in the city of Rio. But Goretti, the users are very pleased with the quality of our health care. All the indicators tell us that. We have a huge vaccination coverage in our city. We have a good coverage for HIV, AIDS in Rio. So we are on the right path in our city. So I'd like to invite all of you who don't live in the city of Rio to please get to know one of our primary healthcare unities, a family healthcare center from our secretary. We have one very near here, 300 meters from Rio, and 1 kilometer far from here, we have a family healthcare center that was that started in the first building that was inaugurated by Mr. Osvaldo Cruz. It was a vaccination center. So welcome to the city of Rio, and please visit one of our primary healthcare units in Rio so that you can see for yourselves what we do. Thank you very much. Now we are going to give the floor for the chief of the Development Bank, Mr. Javier Guzman. Good morning. Muito obrigado.
A pleasure to be here with you all. The first thing I wanted to say is the Inter-American Development Bank is very committed to improving health in the Americas. And we know that one of the key strategies to achieve so is strengthening primary health care. So we're very happy to be here with our partners, the Pan American Health Organization, the World Bank, and of course we're very thrilled to be invited by the Brazilian government and the government of Rio de Janeiro to understand, to learn lessons, to exchange strategies, opinions, and more importantly to think about the future and move forward. So please enjoy the following days and count on the Inter-American Development Bank to action on this strategy and this plan of action. Thank you.
Now we have the floor to the Director of Human Development for Latin America and the Caribbean of the World Bank, Mr. Jaime Saavedra.
Bueno, muy buenos días. Ahora voy a...
Good morning. I'm going to speak Spanish. First of all, I would like to thank the panel and the municipality of Rio for welcoming us. Yesterday, I am in a hotel very near here, and the view is spectacular, the scenery. It is really a wonderful city. Rio is a wonderful city, and Brazil as a whole. Is an honor for us to be able to be here for this alliance. And the alliance has been on for 2 years. Not only it helps the multilateral institutions to have financing and resources, but it shows a political commitment that many countries have already engaged on. I would like to say that at national level, I would like to say thank you for having this space of Paraguay, Chile, the Dominican Republic, that are also present in this event. In those 2 years of the alliance, we are supporting the strengthening of the dialogue and the communication amongst the countries. But also, we want to save lives and we want to improve the quality of primary health care. And Latin America has improved a lot. Thinking about these challenges, we have 4 times more than other countries. So we have improved the quality of primary care, but we know that the experience of people in the system is not ideal. We have clinical problems and we have problems with the experience of the patients. We know it's not ideal yet. And I would like to talk about 3 themes that this alliance has improved, the challenge that we see to all our countries. The first is human resources in the area of healthcare. We must have good human resources. That is the most important thing, the cornerstone for having a quality of healthcare. We have problems with our healthcare professionals and where they are located in our countries. Due to demographic changes, we need 7.3 million more people in the region as a whole. So it's an enormous and continuous challenge to improve the quality in terms of human resources. So we have to select better people. We have to have hiring people to do that in the healthcare system. We have to improve the quality of our personnel. And this is very complex, but it's a must. The second challenge I would like to mention is fragmentation. We have a problem of fragmentation. When the patient comes to the system, it's difficult. We don't know what are the levels of attention that the patients need. Sometimes the patients don't have the right experience. Sometimes there is no follow-up. So sometimes the patients don't have a good experience. And the fragmentation is that in Latin America, the Ministry of Health sometimes have subnational systems that have been around for 80 years and have not been updated. There are exceptions, but we have also heterogeneous quality in the private sector. Chile, Colombia, and Brazil are important countries in this area, but the rest of Latin America is not the same. And the last point is the need to the Ministry of Finances to be also with us. We need their support. We have ministers of healthcare that are engaged, but we need all the sectors to be involved too. The Ministry of Finances must to understand the society as a whole. And the Ministry of Economic and the Ministry of Finances must get involved so that we can deliver a real primary care system of quality. So it's an entrance door to the healthcare. We would avoid then 30,000 deaths per year if we have a better mechanism of access to the finance system. Our system of primary health care would be better integrated to all the systems. So it is crucial for the finance ministries to be involved in our discussion. We have to involve the Ministry of Finance in each one of our countries. And we must go on producing public goods to help the health system, and also to open a political debate that realizes that we need to improve the health system in our countries as a whole. We know that health is important, but we have to be sure that our societies realize that the problem of the quality of care today is unacceptable. It is a social demand to have a better healthcare system. And third, we have to coordinate and have a process of coordination amongst all our countries. This is the place to have that, because we can have multilateral discussions. The World Bank and the Development Bank, we can work together to be sure that our work has a real impact in a better quality of health care, and also to spread this all over our societies. Thank you.
Now, I would like to pass the floor to the Executive Secretary of the Ministry of Health, Mr. Adriano Massuda. Good morning. I would like to say that it's a double joy to be here at the Getúlio Vargas Foundation, where I teach. I'm a professor here in the administration school in São Paulo. And I'm also here as Executive Secretary of the Ministry of Health in the role that in which I would like to welcome all of you. I would like to welcome the 24 countries that are represented here by their ministers, deputy ministers, and technical staff. It is an honor for Brazil to host this second event of the Alliance for Primary Healthcare in the Americas. I would like to thank Honda and Pajo for choosing us, and also the whole staff, including Christian Moraes and the Brazilian staff, which were our partners in organizing this event in such a short time. I would also like to thank the staff of the Ministry of Health and our secretary, Luisa, Dr. Ana Estela Haddad, our secretary in the digital care. And I would like to say that the Ministry of Health was engaged in very intensely, because we believe that Brazil has a very rich experience in building primary health care alongside developing a health system that is universal, comprehensive, and free for our population of over 200 million people in a continental country with so many social inequalities. So the Brazilian system is not only a health reform, it represents also a social change because of all the inequalities we have in our country. I would also like to acknowledge Mr. James Saavedra and thank the World Bank for their partnership in our different projects in healthcare. Also Mr. Javier, representing the Inter-American Development Bank. I would like to thank you, sir. And I would also like to acknowledge Secretary Claudia Mello, who is a Secretary of Health of the State of Rio de Janeiro. I would also like to thank and acknowledge the other secretaries of state that are present here, and the Municipal Secretary of Health of the City of Rio de Janeiro. And we chose the City of Rio de Janeiro because this event is not only for discussions, but also for us to be able to visit and experience knowing that the primary healthcare is a driver for change in the whole healthcare system. And in Brazil, we have several experiences like this, but if they're the most important and innovative one is here in Rio de Janeiro. Rio de Janeiro took some time to do this transformation in its basic primary health care system, but when it did, it advanced greatly and it became an inspiration and a reference for us with their multi-professional teams and with a large coverage in the city of Rio de Janeiro with such a large population and geographical differences, but it seeks also a digital transformation and to be affordable and accessible for the population to primary care, and it's a resolution and it's dignified and it represents the kind of primary health we want to offer the whole population of Brazil. So when we thought about this event, we thought about Brasilia, we thought about other cities, but we were sure that it had to be done here in Rio de Janeiro. So it's an honor to be here, not only on behalf of PAHO, but I hope I know you are all welcome here in Rio de Janeiro, and I hope you have a wonderful time here. And it's a great honor to be able to host this event here, and I hope all of us have a great event, and I hope that it can be as good as the one we held in Uruguay a few years ago, and that we can leave Rio de Janeiro at the end of the event with a reinforced alliance among our countries in such a challenging global context. We must invest in universal healthcare systems and these changes, because it will lead us to a more civilized world and it will ensure healthcare access to all the population. Thank you very much. Right now, I would like to pass the floor to the sub-director of PAHO, Ms. Rhonda Silly Thomas.
Daniel Sorans, Dr. Jaime Saavedra, Dr. Javier Guzman, the representative from Fandacao, Getodu Vargas, Dr. Adriano Masuda, other members of persons here on the stage with me, good morning. On behalf of the Director of the Pan American Health Organization, Dr. Jarbas Barbosa, I'm pleased to join you today in the beautiful, warm city of Rio de Janeiro and welcome you to the second regional forum of the Alliance for Primary Healthcare in the Americas. I say warm because I'm coming from Washington, D.C., so you can imagine my joy of being here in Rio. From PAHO, we extend a sincere appreciation to the Ministry of Health Brazil for their very warm welcome and for supporting PAHO in this important meeting. In addition to the distinguished representatives on stage, I would also like to acknowledge ministers and vice ministers of health from across the region, directors of primary health care, representatives from the Brazilian Ministry of Health, representatives from 24 countries across the Americas and Europe, and delegates from civil society. Ladies and gentlemen, today our region faces an increasingly complex landscape. The demographic and epidemiologic transitions, climate-related shifts, and the ongoing challenges of post-pandemic recovery are placing unprecedented demands on health systems. These pressures do not recognize borders, making intersectoral and intergovernmental collaboration not only desirable, but essential. At the same time, fiscal constraints and social protection challenges demand that we do more and that we do it better with less resources. It is within this context that primary health care remains the most effective strategy to build health systems that are timely, equitable, resilient, and sustainable. However, to implement primary health care successfully, we need more than technical solutions. It calls for strategic vision, agile governance, and bold public policies that foster innovation. It also requires the coherent integration of new technologies and priority health programs while strengthening strategic alliances among countries and within the international community. This is precisely the spirit that led to the launch of the Alliance for Primary Healthcare in the Americas in December 2023 in Uruguay. As a joint initiative of PAHO, the World Bank, and the Inter-American Development Bank, the alliance was established as a unique regional mechanism to accelerate primary healthcare implementation through investment and innovation. Our objective is to support countries in transforming their health systems through coordinated policy guidance, harmonized investment planning, and coordinated action. In just 2 years, the Alliance has built a solid foundation. Together, PAHO, the IDB, and the World Bank have supported countries in assessing their health systems, strengthening policy dialogue, and aligning investment plans, helping them more decisively from strategy to implementation. This second regional forum marks an important milestone. Over the next 2.5 days, we will review the progress that has been achieved, share innovative experiences, identify opportunities to expand investment in integrated, people-centered service delivery, and define the next phase of our collective action. Most importantly, we will reaffirm our shared commitment to primary health care as the driving force behind health system transformation. Let this meeting serve as a space for honest reflection, mutual learning, and renewed ambition. The challenges we face are complex, but our collective capacity to address them through partnership, innovation, and solidarity is even greater. On behalf of Dr. Barbosa, we wish you a very productive and inspiring meeting and thank all of you for your steadfast commitment to the Pan American Health Organization, the Alliance, and to advancing primary health care and universal health across the countries of the Americas. Thank you for your kind attention.
Solicitamos que as autoridades se posicionem.
We would like to ask our speakers to please get up for our official photograph, and we'll soon continue with our event.
Señoras y señores,
Ladies and gentlemen, I would like to conclude our opening session. And at this moment, I would like to call everyone for our first panel, the primary healthcare in the Americas, the need for acceleration in the region. I would like to call the head of the health department, Mr. James Fitzgerald.
Muy buenos días, bom dia, good morning. Realmente es un placer para mí estar con ustedes esta mañana.
It's a pleasure for me to be with here this morning to participate in this important event. I would like to acknowledge everybody who is present here, the Minister of Health, the representatives of the World Bank, and all the other authorities here, and also my colleagues from my team. It's a pleasure to see you after 2 years of the launching of the Alliance for Primary Healthcare in the Americas. It's a pleasure to be with you this morning. And what we are going to talk now, it's going to be revisited in the other sections. The presentation is in Portuguese, and there is translation into English. In my presentation today, I'm going to talk about the importance of PHC. And also I'm going to present some evidence to promote health policies, to promote a better health for the population as a whole. But first of all, I would like to talk to you about an argument, because we have to accelerate our actions, because we have to improve what has happened in the past. On the other hand, I want to present also some of the actions that we have to deliver so that we can advance in a better way. And finally, I will emphasize the how and with whom together the academy, the civil society, the development banks, how we can work better and together so that we can have a more equal future with more health for everybody. So let's start with a question that is the most important one for this day. Why PHC is so important and why now? Why is it different now? First of all, there is the need to have better health care. 1/3 of people don't have the health care that they need. Not that they don't recognize the need, but they have many hurdles, financial hurdles and not financial ones, to get to the service. Second, the coverage of the universal health care has stopped. There was an increase in 82 and 83, and then between 2015 and 22 and 23. But then it just stopped. It has come, instead of going forward, it went backwards. Then we have financial challenges. 15% of the population have financial difficulties due to health expenses, and other 14% just don't even go to try to be attended by the healthcare system due to its high cost. So those barriers are enormous. So last, we have barriers or hurdles that are non-financial. Where are they? Those are challenges in terms of organization and availability, and there are more than 40% of the needs that are not met in the area of healthcare. So this we have to change. It's not only a problem of financing. So we ask, why PHC is needed now? Because people are lagging behind in this area. The financial barriers must be overcome. How can we do that? And due to that, we have some indicators of sustainable development that are limited. The secretary talked this morning about that. We have this problem in the Americas due to the limitations of the healthcare system. Some countries have come forward and advanced, but in the indigenous population, the poor population, the people from the interior, we have high mortality rates during pregnancy and during delivery. Many women die due to barriers in the access to healthcare and the lack of people who know what to do on these services. We have lack of medical personnel too. So we have to change. There is a stagnation in the healthcare systems. And this is due to inequalities both in the social level and the financial level. So this has been harming the health of children and poor women. So we have and also the aging of the population is a global phenomenon. In Latin America and the Caribbean, it is much quicker than in the rest of the world. The population that is over 50 is more than the population of children that are less than 15 years old. It's quicker than in the rest of the world. And this poses a demand not only now but in the future due to health problems and also social ones. In this context of aging of the population, we have an epidemiological transition. So you have a prevalence of non-transmitted diseases, and also we have mortality is expanded during the course of the lives. So life expectancy is affected by that. So we have also an expansion of morbidity. Different phases of one's life. This phenomenon reflects in the cities, and also it's fragmented. And so the health care system has to be able to deal with that in the different phases of people's lives. We have more than 240 million people that has at least one chronic disease. 6 million people died due to chronic problems. Some of cancer, and 38% of those deaths could be avoided. There have been advances in the region. We have more than 10 new health centers in the region, and so they have a better attention and care to chronic diseases, but it's not enough. We still need more. We still have important challenges, mental health, and also the policies amongst the different actors. So the message is very clear. In the PHC and the systems of health should focus in the need of the people's health, taking into consideration the territory, the characteristics, and the population that inhabits the area. So we have these needs, and also the conditions of the population and their capacity. We want to advance the capacity and of health and how to deliver the health system. And this has to be done by the healthcare systems. We have an offer of services, but they don't meet the needs of the people. We have sometimes episodes that are not attended, and we have low satisfaction of the population. We also have heard about the challenges that we have in terms of human resources. We lack almost 2 million people in the area of human resources to have a sustainable development in the healthcare system. We need a process of planification also, and also in the urban areas and the interior of the country, we have a different system and other climate changes and emergencies. Those are some of the recommendations that we have received from the bank, the World Bank, and also the PAHO. So we invite other representations to also contribute to those, to giving us information about that. In this context, we want to present some axes that would accelerate or speed up our action. We have this enormous challenge ahead of us. We have to respond to the problems, to go forward and speed up our actions so that we can deliver a better service. First, we need more resilient healthcare systems that are more comprehensive and also integrated in the different territories and all levels of healthcare, so that we can improve the populations in the areas that we can improve. With different, we have to integrate health and integrated healthcare so that we can have actions to reduce the barriers that are financial and non-financial. And more than ever, we need a social participation that is effective with multi-sectorial actions at the social level, at the local level, and national level to improve primary health care.
En estas bases representa la estrategia para avanzar y lograr la salud universal en las Américas. Y en este marco hemos definido algunas palancas o levers en inglés. Palancas tanto estratégicos como operativos para apoyar a los países en lograr este objetivo. De los estratégicos, el compromiso político, la rectoría y gobernanza, el financiamiento, y los operativos como el diseño del modelo de atención, los recursos humanos, las políticas, su marco regulatorio y acceso universal a los medicamentos y tecnologías. El objetivo es claro: mejorar acceso, utilización y calidad de los servicios de un lado, fortalecer la participación, gobernanza y rectoría de otro, y después abordar los determinantes sociales con la participación efectiva de la comunidad. Las funciones esenciales de salud pública son capacidades y elementos críticos para el fortalecimiento del sistema de salud basado en la APS y ofrece la base para la transformación del sistema de salud basado en la atención primaria de la salud. Están organizados en torno a 4 pilares. ¿No? La primera es la evaluación de las políticas y lo que está pasando en el país. Segundo, el desarrollo y adaptación de las propias políticas. El tercero, la asignación de recursos, tanto recursos financieros, tecnológicos, humanos. Y después, el acceso. Cómo abordamos y romper estas barreras de acceso que están en los países. Desde 2000, la función esencial de salud pública ha sido en el centro de la agenda para el fortalecimiento del sector salud en la región de las Américas. Más de 25 años después, hemos renovado el marco conceptual de esta función esencial de salud pública. Y esta renovación, para tomar en consideración estos desafíos nuevos que estamos presentando, tanto nuevos y además como persistentes, Y en este momento, 17 países de la región de las Américas están en este proceso de evaluación, tienen planes de desarrollo de sus propias funciones esenciales y tienen una visión para transformar su propio sistema de salud basado en las capacidades y la visión que estamos proponiendo. También la APS presenta la base para una atención integrada durante el curso de vida. Y aquí la región tenemos mucho por hacer. Primero, es necesario rediseñar el modelo de atención para responder a las necesidades de salud de personas, familias y comunidades, considerando la dinámica de sus trayectorias de vida y respetando sus valores, preferencias y prioridades. Segundo, es necesario también actualizar la organización de los servicios de salud en redes para que responda a estas necesidades. Busca un enfoque holístico, integral, continuo, proactivo, preventivo, que permite el desarrollo de estas trayectorias de vida saludables. Y tercero, tras estas redes de servicios, tiene que ser bien vinculado entre ellos y también en los otros procesos de organización del cuidado, multisectoriales, intersectoriales, con el sistema de protección social, educación, vivienda, para responder mejor a las necesidades durante el curso de vida. Al fin del 2025, la Organización Panamericana de Salud, el Banco de Desarrollo Interamericano y el Banco Mundial lanzamos un consenso técnico sobre redes integradas de salud, de servicios de salud, un marco actualizado para apoyar a los países en la construcción de redes de servicios basados en la atención primaria de salud y en la evaluación de la maturidad de estas redes y la expansión acelerada de los servicios de salud. Ya son 10 países que están participando en la red impulsora de RIS para avanzar con la medición de estos servicios y la capacidad resolutiva de los servicios de salud. Y especialmente, y más importante, con planes de desarrollo con recursos asignados, apoyado por la Alianza para la Atención Primaria de la Salud. Igualmente, no podríamos hablar sobre aceleración en acciones APS sin hablar de la transformación digital, que nos presenta oportunidades enormes en tres esferas concretas. Primero, en los servicios de salud y en general en la salud pública, en la estructuración y organización de telemedicina, de atención virtual, para mejorar el acceso a los territorios remotos y también para ampliar y expandir el acceso a la conjunto de prestaciones que son necesarias durante este curso de vida. Y segundo, más que nada, para realmente aprovechar de la inteligencia artificial, tanto en la vigilancia sanitaria, que en la organización y proceso de gestión de servicios, en la estructuración y desarrollo de dispositivos médicos, y en el desarrollo de plataformas digitales para manejar y gestionar la salud de la persona y de la comunidad. Segundo, nos presenta una enorme oportunidad de eficiencia, de optimizar la utilización de recursos, no solamente a nivel nacional, pero también a nivel subnacional y local. También entre actores, entre países y entre socios importantes que están llevando acciones, innovaciones, conocimientos y recursos muy importantes para acelerar los procesos de transformación digital en los países. Esta transformación, entonces, está basada en acciones integradas en salud digital. Se basa en los sistemas de información operativas que facilitan la eliminación de algunas barreras de acceso a nivel local. Se permite la expansión de los servicios de salud, sobre todo en el primer nivel de atención. De nuevo, acciones multisectoriales son necesarias y urgentes. Por ejemplo, en inversiones en infraestructura digital, en aspectos relacionados con gobernanza y regulación y el desarrollo de bienes públicos digitales. Y acciones son necesarias también en el sector de salud, en la integración efectiva de la salud digital, en el modelo de atención y la integración de la red, en la aplicación de la telemedicina, los portales de salud y justamente sus procesos de organización en el sistema. Y más que nada en la capacitación de los recursos humanos. la alfabetización digital de nuestros recursos humanos, el personal de salud. Esta es clave si vamos realmente a aprovechar de esta enorme oportunidad que se nos presenta la salud digital. Podemos entonces resumir estos aceleradores en 3 ejes de acción clave. Primero, las estrategias integradas para lograr la salud universal basado en la atención primaria. Implique fortalecimiento de capacidades institucionales, la aplicación de funciones esenciales y después aprovechando la innovación y las oportunidades que presentan estas innovaciones a nivel nacional, subnacional y local. Segundo, un enfoque mucho más específico sobre atención primaria de salud y un abordaje poblacional y territorial para analizar las condiciones de las personas donde viven y sus determinantes sociales para construir en base a estas necesidades las redes de servicios integrados, además con servicios sociales. Y tercero, la atención integrada durante el curso de vida, integrando esta visión de curso de vida que necesita la persona durante cada etapa de su vida para proteger su salud, para proteger las capacidades que tiene, para mitigar contra enfermedades y promover la salud y bienestar de las personas. Estas son funciones claves del propio sistema. Este es el qué. Ahora un comentario sobre el cómo. Y ahí quería tomar un tema que es muy sensible. Es la brecha de implementación que tenemos en la región de las Américas. La OPS en este momento está terminando. Países de América Latina cuentan con un político plan de APS, pero solamente 40% lo ha operacionalizado efectivamente. Apenas 33% de los países tiene sea un departamento o una persona designado para APS y la integración de APS con un abordaje sistémico en las redes de servicios de salud. Falta una arquitectura institucional para justamente tomar estas políticas y hacerlo efectivo. Segundo, las redes de servicios de salud están parcialmente construidos, pero no plenamente habilitados. ¿Qué significa esto? En casi 70% de los países sí están organizados en papel las redes.
These health network systems on paper. However, they do not have institutional agreements between sectors or for governance or financing. They are not feasible. So the architecture exists. However, oftentimes the structure that helps it or makes it feasible are not there. We have also social participation, however, it's not institutionalized or sustainable. And fourth place, the intersectorial action is more solid in the discourse than in practice. 80% of countries have an approach on health in their policies. However, only 28% have effectively implemented them. So there is a gap that is important between the view and the vision we have and the effective implementation of this view. So then how can we approach this? And that is precisely the situation that the PHC needs to be accelerated in our alliance. And that is where our alliance comes in and brings value. We have to move on from theory into practice. We need to have the structures for implementation and the participation for that and turn this into a reality. As we've heard in the beginning, the alliance was launched in Uruguay in 2023 by the director of PAHO and the president of Uruguay, and together with the World Bank and other countries, with a view to see how these organizations could work together in order to support countries to accelerate and integrate these actions and support investment in the primary health units and help foster all of these accelerators and improve the health care. All our institutions are trying to harmonize the policies, trying to give technical access to the networks and countries. And we are working in many of these countries, or all of them, to organize and support the countries to introduce these actions, and our partnership under the leadership of the countries. The Alliance wants to improve the governance and leadership of the countries themselves. We have heard about the importance that the Ministry of Finance should be also involved, right? However, it is also important that the health sector has its own governance in face of other sectors in order to build and act and organize all these key actions on the national level. We have 5 consultative roundtables right now in Panama, Salvador, Paraguay, Chile, and the Dominican Republic. And these were built in order to organize everything under the leadership of the Ministries of Health with the cooperation of the World Bank and the Inter-American Development Bank. And it's working very well. We are also happy to receive Bolivia and Paraguay in this forum, and they will also sign the alliance and join us. So there are many opportunities, and it is very important for us to advance together, because together we can make a difference. We have the knowledge, we have evidence, we have studies, and we have responses for action. And then now we know what we must do. Now we must talk about how we can do this. So if we work together, we can accelerate all these transformations. Thank you very much.
Señoras y señores, neste momento, para o painel Experiência.
Now we are going to talk about we have different authorities now. The moderator of this primary healthcare unit from PAHO, Mr. Ernesto Báscolo.
De Bolívia.
The Minister of Health of Bolivia, Marcela Tatiana Flores Sambrana. The Minister of Health from São Vicente and Granadini, Mr. Daniel Comics. The Secretary of Primary Health Care from the Ministry of Health in Brazil, Mrs. Ana Luisa Caldas. The Deputy Minister from Panama, Mr. Manuel Sambrano. The Municipal Secretary of Health of Rio de Janeiro, Mr. Daniel Sorans. Good morning. First of all, I'd like to acknowledge my colleagues at the panel, Marcela Sambrana, Daniel Comen, Dr. Ana Luisa Rodrigues Caldas, Manuel Sambrano, Mr. Manuel Sambrano from Panama, Daniel Sorens from Rio de Janeiro. I'd like to welcome you all, my colleagues, ministers and deputy ministers, distinguished delegates, and all the partners of the alliances, not only the authorities, but all the teams from PAHO and the World Bank and my Brazilian colleagues who are present here today. It's a pleasure to be here with you in this first plenary of debate and discussion about the transformation of the healthcare systems. The alliance was created 2 years ago exactly to get together and to unite our forces, our strength, to transform the healthcare systems. We recognize that we have important agreements of where we wanted to go, but we needed to recover a narrative that had been lost. We have to unite our efforts so that we can thread this path in a national way. We know that when we're talking about PHC, we are talking about a pillar that undoubtedly is fundamental, is critical, and we have many consensus about that. Most countries have become our partners, but we know that the transformation of the health systems with emphasis on PHC is a challenging process. We can repeat the slogans, but they are very difficult and complex to be implemented. As we have seen, our healthcare systems are very fragmented, segmented, and they are insufficient in terms of financial resources and also human resources mainly. And I would like also to highlight a component that concerns us a lot, that is very prevalent in our region, that are the inequities, socially and financially speaking. Not only inequalities in terms of coverage, but also in the access to healthcare systems. This is critical in our region. So those transformations that the Alliance created 2 years ago, those we have to talk about longer periods for transformation. And I also would like to highlight something that we have already mentioned. When we mention the need to say what and how. And this implies the discussion not only repeating the need we have about the importance of PHC, but also discuss how we can change and transform the primary healthcare system. How can we change the narrative and put something in real practice? And this demands an effort not only of political decisions, but also of critical analysis of how to follow this path. So I'm not only talking about restrictions in structural terms or institutional characteristics of the different healthcare systems that doesn't favor our process, but I'm talking about the capacity, the limited capacities at subnational level, at the level of the territories, the municipalities, the states, so that we can put into practice a narrative that we all agree with. But it's very critical to put it in practice, to really deliver this system, this healthcare system, so that we can go on in this path. In this first plenary session, we are going to focus in the management of change. So we want to share lessons learned that are useful to the region. So we are going to analyze the conception of PHC in the different contexts, how we can change that, transform that, and the kind of actors that should be involved so that we can guarantee that the policies change. We have to recognize the different steps of the process. The issue of change leads us to recognize the different contexts and the different situations. What happens in the Americas and the capacity to recognize the diversity we have in the region. So it's not one size fits all. We have different regions, and we have to emphasize how we are going to arrive at the process of change. We have to inspect the diversity. We have the diversity in the Caribbean, the diversity of a country in Central America, the diversity of an Andean country like Bolivia, a continental country such as Brazil, and a very interesting experience in the municipality of Rio, for instance. In each of these cases, the issue of change leads us to recognize and transform structures, frameworks. We need changes in the public health system that is linked to governance. In each context, we have to interpret the structures, the frameworks that are institutional and organizational ones also, that are the vectors of this transformation. I have 4 critical aspects to mention that should be in our minds each time we think about change. And first of all, change has to do with political change. The political component is critical. And how it has already been mentioned, we need to think what are the alliances that are critical at the regional level, but also at the national level. I have to highlight the need we have to add new actors to strengthen the Ministries of Health and the Ministry of Finance. But we have other social sectors that should be involved if we want to guarantee the intersectoriality in our different territories. And I have also to mention that the political processes also need a consensus in the different territories. How can we achieve the fact that the civil society, the medical sector, and the different territories and the institutions can get together? They are not only urged to be in this action, but they should be part of this collective action. Secondly, when we talk about change, I would like to mention that this issue of change leads us to think about the trajectory of this transformation in the healthcare system. We must have political will for change. It's important to take advantage of the opportunities that we see in these political contexts. It is important that the leaders of the process of reform in the healthcare systems understand that we have trajectories that change and mature over time. Each step has different challenges and different conflicts. Each country will address that or approach that in a different way. So it's not one size fits all, as I have said. We must understand the diversity and the political diversity in each context. On the other hand, I would like to say something that seems obvious, that has to do that to manage change, we need technical capabilities. And we have to recover that when we look in a basic way, but that is a must. We have to recognize what are the demands of the population, not only that, what are their expectations, but what are the needs of the population. So we have to recognize the capacities in each of our regions. It's like a slogan, but taking into consideration the life conditions of each population and how we can approach and address their problems using the resources, the actors, and the interventions that are specific to each territory. So we have to develop technical capacities. We are not reinventing the wheel, but we have to develop technical capacities that we lack nowadays. And there are new technical capacities that are indispensable so that we can really get to change. At the end of the afternoon today, we are going to have a plenary about digital transformation and artificial intelligence, AI, that are really critical to speed up and accelerate the process of transformation of the system and of the healthcare services. So this is my introduction, and now I'll give the floor to my colleagues. First of all, we have the first presentation, Dr. Marcela Flores Zambrana, Minister of Health from Bolivia. Good morning, distinguished authorities from PAHO, from the Ministry of Health of Brazil, from the World Bank, and the Inter-American Bank, and all of you who are present here. So I bring the salutations from our President. First of all, I would like to share with you the structure of our Ministry of Health. We have a system that is very much fragmented and segmented, that doesn't coordinate the several different levels. The hospitals are not in good shape, and we also don't have an adequate distribution not only of finance resources but also human resources. Our Ministry of Health is in debt not only with the corporation ministers but also with the private sector that render services to chronic renal problems, cancer, and ICUs. Our public hospitals are in bad shape. In last year, in November, we had a change of government, and so we established a new model of management. And in this new model, we have all the social actors and also the local ones. And we have different pillars. The first one It's called Bolivia Economy for the People. We want to strengthen the investments in the small producers and farmers. The second is Bolivia to the world and the world in Bolivia. It's to help the cooperation. After 22 years, we had our first interagency meeting. Bolivia 50-50 is to decentralize not only the economic framework, but also education and health. Modern Bolivia, efficient and modern Bolivia, is the digitalization of everything in Bolivia. Transparent Bolivia, we have programs of fight against corruption. Green and sustainable Bolivia is our commitment to the environment and well-being, Bolivia well-being for everybody. It's health and education. This is the most important pillar in the new government program. Our health system in Bolivia, we have the Ministry of Health that is to reform and realize political strategies, policies, plans and programs so that we can have different levels of health care in the different sectors. Our service renders are within that. We have a subsector that is for public health. We have 2 other levels, 3 levels, and now a 4th one. They are distributed in the different states and municipalities. We have the subsector of social security with 14 sectors. Some are bigger than others. And then we have the private subsector of health. We have then the private clinics, laboratories, pharmacies, and also civil societies where we have the NGOs, foundations, and the churches. Now, what is the historical evolution of the PHC in Bolivia? The most important facts are 1978, the alma ata of the law of the participation of the popular in. We had the doctors, and then little by little this action took a new face, and we had different clinics at the different levels of attention. In 1994, we had the law of popular participation. Then we started decentralization process, so the municipalities could manage the 1st, 2nd, and 3rd level of health, and so the different states could manage, and the human resources also. We consider that this was very important to allow a new planning of the health system from the local municipalities. But it didn't do so well because different municipalities had different faces. We had big municipalities that were strong economically and also in the number of people that could manage health. But we have also very small municipalities that didn't have enough resources to go ahead with investments in health. In 1996, we had our first insurance, health insurance, that is called the insurance for maternity, to diminish the maternity deaths and also for children. And it's maternity and for children. And it's not a universal for mother and children. to reduce the mortality of mother and children. In 2008, we had the policy of families and the community in an interculture. That's for different communities to have access to health care nearer to the remote regions. We had not only traditional medicine, but also intercultural one. Between 2019 and 2026, we created the Universal Health System, SUS, with free health care. And we had 70% of the population included in this social security system, because many were not included. And on the other hand, we couldn't have this universal health system because we have a segmentation of sectors. Our sanitary systems are very diverse. Now, what do we want to do between 2025 and 2030? We want to have a modern health system that is integrated to deliver health care to this kind of population in the photograph. We are a country in the Andes region. Bolivia has a diversity in terms of regions. We have the Andes, we have the Amazon even, we have the tropical regions. So our profile in terms of epidemiology is totally diverse. So to build a health system, we have to take care of different bases to meet the demands of different populations. Our critical pathway is to review the laws and regulations to have one and only health law for the whole country. We have to integrate the health services. That is one of the pillars of primary health care. We must have integrated health systems. We must have comprehensive healthcare networks. They are not integrated in my country. And we need a coordination amongst the public and the private system. Our aim here is to design and implement private-public alliances to integrate those networks. We want to strengthen our SUS system that we call SUS, so that we can have a better distribution of human resources and also of the budget that will allow decentralize our government from national to municipal, so that we can have an integrated plan of healthcare systems. The immediate actions that we are implementing is to avoid the collapse of our hospitals of the second and third level, to avoid that people come at 2 in the morning to be in a queue to be seen by a doctor. So we want the population to have access to health care via computer or via a cell phone with telemedicine. Not everybody has access to digitalization, but we want to have this first level of health care to be in a certain time. You have a consultation, you have an appointment. You don't have to be in a huge queue in the early hours of the morning. So we include in that digitalization. We want to have lab exams, pharmacies, and also consultation when the patients come to the second or third level. They can be seen immediately by the clinician. A second point is to increment the capacity to take action in this PHC. This is the entrance way to diminish the fact that the non-transmitted like chronic renal retinopathy, cancer, for those chronic diseases, we have designed the strengthening of the PHC in health and also the increment of human resources, so that you have at least the attention after 12 hours or 24 hours in those centers. And we have the permanent training in digital way, so that we avoid human resources to have to go from one place to another for their training. And third, we must have some establishments, some hospitals of first level of healthcare. The epidemiological profile, we must have an expert that can solve very quickly some pathologies, like in the western part, and we must have dermatologists. In another region, we must have other specialists. We consider that in this way we will diminish the people going to hospital, because you can solve the problem at the first level of attention, and we have an adequate control of the patients. Then we can optimize the resolution capacity of the second level of healthcare. Now, SUS have a very small portfolio of services that is restricted to the second level, and they have the capacity to solve problems only at the second level. And we want to include the third. And third, and finally, we have the decentralization. We want to decentralize our healthcare system, because there are some states and some municipalities that can do the governance of their system. What are the priorities in national terms? To increment the capacity to resolve problems at the first level, to reduce maternal and neonatal mortality, also having programs for those services. The digital transformation also we need in Bolivia. We have to start building our protocols for healthcare based in our own evidence, not the evidence that we receive from abroad. We must have our own research and our own evidences. And we must have an interoperable platform. Now we have 173 different systems, and we have to integrate them all. And we must also broaden our services of telemedicine or telehealth for 84 establishments of second and third level. And they have experts that will help the first level to solve in loco the first problem. And we have to consolidate our universal system of health, not only in the public sector but in the private also, and promote our capacity of research, and also create the parameters so that we can have a committee of bioethics. We want to reduce the neonatal and maternal mortality, because we still have a high level of death. We want to improve our normative framework at the first level of care. We have two initiatives. One is for congenital cardiopathies, just by doing the saturation of oxygen at the first level of attention when we start the first controls of healthcare. We have also to take care of the risks and the complications in the 3 levels to strengthen the human resources in the first levels of attention, integrating all the medical doctors in the different clinics and hospitals, and also incrementing the number of beds in our hospitals. What is the strategical change that we want? We have to focus in prevention and to promote health at all levels. We need a system that addresses cure, but we must have an attention at prevention, strengthening the capacity of the first levels of attention, including sustainable health care and extending the service to the community. We have to prioritize the prevention health. So then we diminish the demand, or we reduce the demand to health care. We have to increment the capacity of our hospitals and clinics. And we must have a clear governance with a model that is robust, with structural reforms. This is key to build a new model of health to my country, Bolivia. Bolivia hopes to abandon a fragmented health system, and we want to build a more inclusive system. Our universal system of health should be an integrated system of health that will guarantee that every Bolivian is not excluded from the access of health. We want to be more modern, with more capacity of solving problems with essential experts, with telemedicine, that we can include communities that
we have the main hospital and we have 3 polyclinics. I find the terminology primary health care very intriguing. As an engineer, I'm trying to make sense of the health professionals' understanding of that word. And so I went to a definition as presented by PAHO and got even more confused. Now, we are in the process in St. Vincent and the Grenadines of building a state-of-the-art, so we like to think anyway, hospital. And that hospital for our small country is costing us about $160 million US. For a small country, that's quite a bit of expenditure. There has been an attempt over the past 15 or so years to make healthcare reach people where they are. And the previous administrations seem to have the idea that the more you build clinics in every district, that is primary health care. I totally disagree. And I come from a perspective of having been a shadow minister of health for the past 15 years, criticizing just about every aspect of healthcare in our country. So I come to this job with my own personal perspective, and I wish to share with you a few of the concerns I have on health general and our approach in the region to it. If I take the simple example of the increase in renal failure, in our country, and it seems to be a regional thing. The government started its public dialysis facilities, and it started with less than 10 persons being treated, and in a few months it's nearly 100 people depending on dialysis for life. I am not aware that there is sufficiency of investigation into the causation of this relatively sharp increase in renal failure. I know we have excellent quality of the water and so forth. But I'd like to see some agency involved in trying to, what I consider to be primary health care, in trying to arrest the causes of this significant increase in renal failure. Similarly, the prevalence in my country of the non-communicable diseases is astronomical, quite frankly. For a country that has good soil and is in agriculture, our population feeds almost exclusively on imported, highly processed foods, the fast foods and all of that goes with it. From where I sit, primary health care should be going into the primary schools, indeed even into the preschools, and encouraging the children to eat what we grow. And really helping them to understand the importance of diet in our health. There is not enough of that. There are some attempts, but my perspective, we needed to join with the Ministries of Agriculture, of Education, of the allied agencies to spread this gospel of going back to basics. But beyond that, the average household, I've come to understand, would tell you it's all well and good for you to say that I should eat greens or I should eat this. Have you looked at the price of these things in the supermarket or in the market? That's what they're going to say. And here's where I differ again. I say primary health care should be looking at mechanisms for enabling householders, even in areas where they do not have land, to look at agricultural practices that permit them to grow a certain amount of the required food that they can consume. Because we know that there are techniques that permit them to grow in buckets, in containers, and so on. Similarly, there are so many persons in my country who come to the clinics or end up in the hospital complaining of aches and pains and things that they don't know of, only to find that their sugar level is astronomical, their pressures have been high for a long time, but they paid no attention to it. And only when it is too late, they end up in the hospital. Again, I have a strong recommendation, and I'm going to see it practiced in my own country very shortly. And that is simply this. Going into each community, especially the remote ones, getting key players together, training them how to monitor the basics, sugar, pressure, etc. But going further and giving to them the equipment that will allow them to do their own testing and the warning signs that they should be aware of and who to contact and so forth. In other words, I see the need for greater emphasis on urging our people to be aware of their bodies, of what makes it tick, and to be in a position to monitor for themselves and avoid the myriad of catastrophe that comes when it is left for too long. The the levels of amputation in my country is far too high. And unfortunately, most amputees are literally cut off from society because something as minimal as prosthetics is not available. So generally, when you lose a leg or a limb, you become a burden on the society. And as a final point for my own, from my own country and how I would like to see primary health care being attacked, has to do with the prison system. We have a fairly high prisoner population, and many of them suffer from these diseases because they're fed a diet of rubbish, literally. White rice and chicken and so forth on a sustained basis. My proposal is and will be to my government to have these persons involved in the prisons become involved in agriculture. There's good lands on the compound of the prisons. They must be made to farm those lands so they can feed themselves well. In fact, I want to go further to insist that the produce from this venture be used in our schools so that the schools feeding program could be assisted by this generous source from persons in prisons. And with that, I thank you.
Thank you so much, Dr. Daniel Cummins, for your presentation. Por favor, Ana Luisa.
Now, Ana Luisa from the Ministry of Health of Brazil. Good morning, everyone. I would like to thank my colleagues from the panel and say that I'm going to bring some quick comments about our primary health care in Brazil and how we have evolved in the last 35 years all over Brazil. Our universal health system is very big, and it has to do with the management of the government. It's a political decision of bringing the unified health system integrated to everybody in the Brazilian territory. I think that our representatives here from all the agencies who are here have said that it is a political decision to have sustainable healthcare systems. And looking at the Americas, we see that we lack maturity, mainly when we look at the decisions that our politicians have taken in the last few years. So first I would like to tell you a snapshot about the unified system in Brazil, the SUS. We have a tripartite organization. We share the responsibility at the federal level, state level, and municipal level. So this has to do with a political decision and also a co-founding of the strategical policies and the programs that we offer our population in general. We have three pillars of the SUS in Brazil, and it is integrality, universality of the care, and equity. Those are the three main pillars with which we work in the SUS in Brazil. And also it encompasses our PJC. When we look at primary health care in Brazil, it has evolved. And if we look at the last 35 years of our SUS, we also have a political decision in the last 31 years the fact that we did PHC as the main entrance to the SUS. And this makes a total difference when we look at the past, the present, and look at the future we want to our population. When we look at the snapshot at the national level, and what you will see from my colleagues that are not from Brazil, and Brazilians who have come from other states can come and accept the invitation by our Secretary of the Municipality of Rio, so that you can see in practice what we preach. We have conquered a lot in national terms. Everybody has mentioned that Brazil is humongous, is a continental country, but the population is also continental. If we look at the historic cut of Brazil, we have more than 2 million people in Brazil, 200 million people in Brazil. But we needed lots of political decisions so that we could really create national programs of health. And today, PHC is the most important one. When SUS was created and the family health care, we have landmarks of almost 55,000 teams all over Brazil. So this means a quality of facility, availability of access, and also quality. But also we have some warnings of how we still lack access in some places. We have to extend the national coverage. In 2025, we have 55,000 teams financed by the Ministry of Health. We could say that we had one team of those that I mentioned is responsible by 3,800 people, nationally speaking. But when you look at the map, we are not fair all over Brazil. We don't have an equal system all over the country. You will see that in urban centers like Rio, it is good, but if you come to the north of Brazil, where we have the Amazon forest, we had other challenges in terms of population. It's difficult for people to access health care. We are talking about teams that are available to the population, but for the population it's difficult to go to them. They have to go over 14 days on a boat to get to health care. So these are very complex sceneries that we face as challenges in Brazil. And all the coastline of Brazil up to the south of the country, all these area, we have also frontiers with other countries. So we have to reinforce our primary defense. It's important in this alliance the fact that we can potentialize the actions in the borders of the country. When someone comes to Brazil, that person becomes a Brazilian for our unified health system. That means that those people can be hospitalized, they have access to PHC, they will have access to renal therapy, to hemodialysis, because the system is unified and universal. So we expect for the other countries from our border can offer the same to our population when a Brazilian goes to their country. So this is a way of really working in terms of equity in the American region. But the country is enormous, so we have different contexts in terms of differences. So there's not a recipe or one size fits all. We had different strategies to meet the demands of our different populations. So we have been reforming in the last 2 decades our system so that we can go on giving the basic PHC. And I have to call your attention to some important points here. Mainly the biggest program that we have to provide medical doctors, that is called More Medical Doctors. It was created in 2013. We had people from other countries going to remote regions in Brazil, and it's recognized. And this fact that we have this program that is called More Medical Doctors. So we can provide a workforce. And this is a challenge, as it has been said beforehand. It's difficult to provide medical doctors. So we have this program, More Doctors. And the challenge becomes bigger and bigger when we look at our peers in the American region. Anyway, so I would like to call your attention also the fact that we invest more and more in the people that we call public health care in the prisons, the prison population, because we have transmittable diseases and we have groups that go there, but it's not as good as we would want. How can I reduce inequality if I don't look at the teams that take care of the people that are homeless, who are very fragile? So we are building in Brazil. It's not only looking at the big urban centers where people are aging quickly and they need public health, but we have minorities also, and we have to focus on them so that we have an equality in the system. For many years, we worked with major programs, but we didn't have a free access that is universal and unified to health. The federal government 2023 put in the Brazilian constitution the fact that all Brazilians can have access to health care. Free health care. We have more than 35 teams of buccal health care all over Brazil. So if you are diabetic, you have to take care of your mouth, because our food goes through the mouth and they are processed, ultra processed. Unfortunately, people don't have healthy food stuff. So we decided to put buccal health also inside our SUS system. And we invite our peers to do the same so that we can have more coverage in the buccal health system in the region. And we have here, in terms of innovation, best practices, and also challenges in the PHC. We have to integrate information, so we use a digital health to increase access and quality, to integrate actions and safety. But we still have to offer telemedicine, telediagnosis, because the country is so huge that we have to look at populations that will have difficulty in going from one place to another. So with telemedicine, it would become much easier. We have a positive snapshot in the region as to contraceptive methods in our unified system. We have the GIU to all women are available. People that come to SUS. We have contraceptives. And we also have the subdermic implant for women from 14 to 40 years of age. And this is for free. You don't need to go to the private system. So we leverage some countries in the American region. So we exchange experiences so that we implemented this system of contraception for women from 14 to 40 years of age. So I'm talking about the acquisition of more than 1,800,000 of implants in Brazil. So it's a political decision to acquire, to buy those devices so that we can advance in those technologies, so that we can offer them for free. There has been a reduction in maternal mortality since the creation of the SUS, but we have to improve those indicators. We cannot improve if we don't give the opportunity or the quick testing for everybody all over Brazil. So we offer rapid tests not only of pregnancy but also of SDTs, so that we can give access and immediate treatment via PHC. When we talk about reproductive and sexual health, we must talk about SDTs. And the schools are the best place to talk about education and health, not only also sexual and reproductive health, but also healthy habits of food stuff, and also the fact that you don't smoke anymore. Talk about familiar agriculture, improve the way we eat, to eat more healthily so that we can avoid chronic diseases. During our lifespan, we have to work that at the schools. Brazil have more than 100,000 schools where we have programs of health care, and we promote health and also prevention in the schools. And we have matured a lot in the last 35 years, but we still need a lot more so that we can have social participation. Social participation is not only a detail. It's something major. We have to listen to our population. What are their major needs so that we can meet their needs in the different territories? And looking at our unified health system, our workforce are women. So we have to look at women and have policies and programs that focus women and women's health, because they are the majority in the PHC. They enter the market, the work market, very early, and they need health care focused on them. And it involves social development, justice, and how can we offer care for people, mainly those who are very ill and are at home. So we must have multi-professional teams that go to the household and care for those who are old and frail. So we have people aging. We have aged populations more and more. How can I bring to these people PHC in these areas? We have to reinvent ourselves. We are creating new strategies to offer better care with telemedicine, using technology, and also to have a better health care for everybody. We have enormous challenges. I think ours are similar to other countries in the Americas. We have chronic underfunding and territorial inequalities. So our SUS system is underfunded. We need more investment. In terms of federal government, we have 250 million reais being invested yearly. But this is still not enough for what we need to offer free health care to our population. So we have to face the post-pandemic challenges. Our population is more poor. How can we offer care with more quality and less resources? This is our main challenge. How can we suggest improvement? How can we innovate? For PHC. So those who need go to the secondary health care so that we offer PHC for those who need it most. And we have commitments with the UN, the 2030 Agenda, and also the cooperation with all the countries. We have more than 144 border cities in Brazil. So we have to make it easier for those people to access health care, mainly for those who are most vulnerable in our frontiers. That's what I had to say. Thank you.
Muchísimas gracias, Ana Lu.
Thank you very much, Ana Luisa, for your presentation. Now we would like to pass the floor to Dr. Manuel Sembrano, Deputy Minister of Health from Panama. Good morning, everyone. I would like to first by thanking the PAHO, the World Bank, and the IDB that since the beginning of our role as minister have been supporting us in the PHC. These were conversations we've been having since the beginning of the project and the beginning of our vision for it. And it was a very simple vision we had. In Panama, we have invested many resources in healthcare, in the public healthcare system, updating our systems. We have the most updated systems in the region with very sophisticated equipment. However, we are still also investing much in treatment, which for me represents a failure of our preventative actions. Dialysis, for example, that are increasing. And what does that mean? It means that at some point in our trajectory, we have failed. We have not done things correctly, like chronic disease, like high pressure, obesity, diabetes, and many other complications that are complications of these conditions had led us to need all these high investments all over the country in dialysis. And this is a result of the quality of life and the lack of prevention, the nutrition that hasn't been reviewed, the bad nutrition, the lack of exercise. Ladies and gentlemen, our children today have fun with on screens. They do not exercise, and these are very complex realities that we must analyze and we must raise awareness among the population. We have a severe problem regarding education and awareness. And now I am going to approach and address what we are doing in our country regarding all of this. We are a very small country, and we have suffered with failing structures in our healthcare system. We have a public healthcare system that has provided care by the Ministry of Health, but also by the Ministry of Finance, or the Caja de Seguro Social as well, and that makes us discriminate among us. And this fractioning of care prevents us from developing a correct strategy for PHC focused on the individual, on the family, community, and the environment. As a result of this division, we have parallel structures in different areas, for example, in which we have surgeons on the one hand, and on the other, we have the anesthesiologists. But we cannot have surgeries because they're not placed in the same institution. And so where we have surgeons, we do not have anesthesiologists, and where the anesthesiologists are, we do not have surgeons. And this is a reality that we have been facing in the past few years. The president of Panama, Mr. Jose Raul Molino, when he learned about these deficiencies, he mandated that Article 115 of the Constitution must be followed, which mandates that these two institutions work together, or they must fuse into one in order to implement the policies. So this is crucial. We have the political goods. Unfortunately, public health is a victim of this politicization and political will. And in this context, these integration processes that have begun many years ago, in 1973, for example, we saw the first initiatives in trying to unify these systems to make a comprehensive system. And today, because of a lack of political will, this has not come to be. Today, our president has put this as a goal of his to integrate and make healthcare universal for all 4.5 million people that inhabit Panama. Everyone must have access to the healthcare system in an equal manner. We will have a health system with effectiveness and equity. Right now, we are beginning to implement this in 2 provinces, Los Santos and Guerrera, and we have a deadline that the president wants for us to present the first report in March about the development of this process of health integration. So, in fact, in the capital city, we are already unifying the system. But what is important is the provision of health, and that there is no difference between those that are insured and those that are not insured. For example, we already have kidney transplants that are available for the people that they were used to be done by the Caja de Seguro Social, the healthcare system, and now they're done under the Ministry of Health. Also, liver transplants are being done with more technology by the Caja. And those that are not insured also have access to these services. We will be able to develop our primary health care based on the individual, the family, the community, and the environment in a sectoral way in which the medical doctor and his staff will be able to follow and control the family and be responsible for them, ensuring the continuity of the healthcare provision with information about the people and the environment and community. Since 1973, this unification process, alongside the political will of the government, this shared view from the Ministry of Health and the president of the Caja de Seguro Social, are with technological tools to promote these actions, has brought us the ability to conclude this process in 2 years. This is the current vision of our government in Panama. And I would like to emphasize that both authorities, the PAHO, the World Bank, and the IDB, are aware that our president has dedicated a great part of his mandate to health. When he makes his presentations and speeches, he always begins by talking about health in all levels, even for animals, because we must also include them in health. So we have a very comprehensive view and a very integrated view that we know that there is no difference in health care. Doesn't matter where in the country. Our goal is that our patients and our population feel satisfied when they approach the public services, wherever they do that in the public health system. We have many facilities, and we want them to feel as well in the public service as in the private sector. And that is why we are seeking technology and telemedicine, radiology, everything, artificial intelligence, all the new tools that are available for us to be able to develop all the technological aspects in order to provide healthcare for our population. We are taking telemedicine to the remote areas of our country. We are also trying to integrate these areas with new centers so that we have the needed coverage. And that is our obligation, to decrease the child mortality rates and other mortality rates, those that affect especially the indigenous peoples and communities. And that is part of the commitment stated by our president and our Minister of Health, Mr. Fernando Boigale. Thank you very much.
Ahora tenemos la última presentación.
Now we have the last presentation. We are running late, but we started late. Now we have Daniel Soran, Municipal Secretary of Health of Rio de Janeiro. I'm going to stand up. So I know you are tired, so I'm going to also nobody falls asleep. I would like to start by saying that we are where we are with the support of President Lula, that helped us or has been helping us since our first government. I am from Rio, but I am the leader of PHC in Rio. I have been the leader for 15 years since this reform started 16 years ago, or 12 years, almost 13. I am the leader of the Secretariat. So I have to thank, on behalf of our President Massuda, President Lula, because we had horrible moments with the previous government that we didn't have a budget. We didn't have enough money. It was a government that did not invest in health. I have to thank this present government, Minister Massoud. I thank you and all the others that have helped us. Secondly, I would like to say that I'm very happy to have you here to host this meeting in my city. I'm going to talk about some things that make sense to me. Sometimes we think we are different, but we forget that we have scientific evidence for everything. When I treat someone with syphilis, I use penicillin for the treatment. Why? Because we have scientific evidence that leads me to that, to use penicillin for syphilis. We cannot make a decision in our system without looking at scientific evidence. So I'd like to mention some things that we value. What were the basis, the scientific basis of our reform? And there is a slide that I always put in all my presentations, is the basis, the cornerstone of everything we do in Rio. That's it. This is the basis. There's loads of scientific evidence so that we can go to the attributes of PHC. If we do PHC, there is a prerequisite that is the access, the very first contact that sometimes we don't value. This is a family clinic in one of the communities in Rio. And we think that everybody must know the name of the doctor responsible for your care. What is the name of my doctor? What is the name of the nurse who treats me? What is the name of the community agent? I would like to invite you to go to one of those clinics and you ask someone there, a patient there, what is the name of your doctor? And he will know, or they will know. This is the bond that we make between the professional and the patient. Each team have their own list of patients. I know who I'm going to see. I know the list of those who have hypertension, of those who are diabetic. You can do that in all the territories, everywhere. This is our main and major challenge. And how did we do that? We created a system, a digitalized one. You put your address, and from your address, you know the name of the doctor, the nurse, the whole team of family health. This is the address of my home, so I know the name of the team, the doctor, the nurse. So in anywhere, the richest or the poorest region in Rio, you know your reference team for your health. This is the cornerstone of our system. Nobody asks for a very sophisticated exam or test if the team of healthcare does not allow. Each team of family health has a WhatsApp number. So you know the name of your team, but you also know the number of the WhatsApp of your team so that you can talk to your community agent or your doctor. This is very important. I would like everybody to have that. If we had a PHC that had this kind of bond, it would be easier for us to go forward. And another important issue is the follow-up. As time goes by, we have scientific data to prove that, how important this is. The previous government, they didn't use teams anymore. It said each person who arrives is going to be seen by the doctor who is there at the time. In 2 years, our system, our health system, was destroyed. We didn't have longitudinality anymore, no follow-up. So our system has suffered a lot. And I cannot forget how important this follow-up is. This is the indicator that we use, the percentage of consultations that your family doctor had. Because when we started the reform of PHC, any doctor would see any patient. As time went by, we had an indicator. We were between 70 and 90% of the consultations were carried out by our own doctor, the one responsible for your care. It's totally different from just arrive there, anyone will see you. Of course, it makes all the difference. Now, with loads of technology, now we have a medical chart that is integrated to the whole of Rio. How many pregnant women we have right now in Rio? 26,770 pregnant women in Rio. How many of them use folic acid? How many of them use calcium? How many are hypertensive? How many are diabetics? So this medical chart shows how those who didn't take the vaccine for SRC. So the community agent goes to her household and applies the vaccine. So each pregnant woman who has hypertension, how many of them take this medicine or that one? What is the percentage of women who has to take AS? All of them, but only half of them had AS prescribed to them. So we are not going to reduce maternal mortality if I don't use technology to examine that. So all of them have to take this kind of medicine. So we go and visit those who didn't take the right medicine, or we tell their doctors to use it. We have been doing that with the main health problems that we have in Rio. I'm almost there. But another essential issue for us is to have an integrated service. We have different programs that coordinate care for pregnant women, for our teams, and so on and so forth. I would like to take advantage of your presence here to invite you to go to the CIE, our Center of Epidemiological Intelligence. All our databases, all our systems are there, reunited in this place. Minister Flores knows this very well. Thank you for your work at the ministry. You have made our lives easier. We have this Center of Epidemiology. We know how many people were bitten by an alligator in Rio. In Rio, we have people who think we are in the jungle. But we do have cases of 24 people who were bitten by an alligator in the city of Rio. And from the data, we can see this in real time. Nobody died. Everybody is alive and well. But we had those number of bites by alligators in Rio. We can monitor via this center how many patients of tuberculosis we have in Rio. And we also value the change of habits. So we have this program, Carioca Gym. Many people, 90% of people had their pressure controlled. 19% don't take the medication anymore. 81 of them were able to reduce their body mass index during the academy, this gym that we have on the squares in Rio. Another important thing is that we have technicians in the different jobs. So we have established the aims of those people. And now we have this global movement that is for to have universal health systems. We created the day of SUS Pride. So once a year, we choose a day, and all the professionals, everybody involved with healthcare, posts in their Instagram, in their Facebook, their commitment to develop our unified health system, SUS. Everybody is committed in developing this system that is for free and has lots of quality. We have this scientific publication also that magazine publishes everything that we do. And to wrap up, I would like to thank our mayor, Mr. Eduardo Paz. We inaugurated this clinic in Rocinha, a community in Rio, and we have to reform our health system, but we have to reform society as a whole. We need political will. This is the mayor, Eduardo Paz. He is going to run for governor, and I'm going also to go with him. I would like to thank my team from the Municipal Secretariat of Health. I would like you to stand up. This is my team. They work with me. And you can talk to the people from other countries so that you can lead those visits that you are going to have in the afternoon. It's important for us that you see what we are doing, but more important yet is to listen to your suggestions and your critics, why not, so that we can go forward with better quality. Thank you very much for your attention. I hope we have a fruitful 3 days. Thank you. Thank you, Daniel, for your good presentation. And I think that now each one of us in this panel could describe not only your own situation and what are the characteristics of the policies of PHC in your own countries or cities, and also how to go from what to how you are delivering and putting into practice those initiatives. I think that the visits we are going to have in the afternoon will show this experience in a lively way. How is the practice in the municipality of Rio de Janeiro? Now we are open to questions and answers. I would like you to ask questions with the same orientation. Not asking about details, but how those actors somehow think of how to speed up this transformation process. Now we are open to the Q&A from the audience.
Acá me dice la ministra, está muy bien entendido.
Well, I guess if we don't have any questions, either everyone understood everything or no one understood anything. It's either black or white.
All for the night.
Muito obrigada.
I was just wondering what are the most challenging parts, especially in Brazil, about implementing e-health, mental health, because I know in a lot of countries they don't move so quickly with e-health in especially the remote areas. I listen also to Bolivia, and I know that maybe Brazil is a bit further with e-mental health and e-health. So I was just wondering, what are the most challenging moments for you to implement this?
Gracias por la pregunta. Vamos a ver si hay otras, así con.
Okay, that's our first question. Let's see if we have any others so that we can combine them. Okay, do we have any more questions? Okay, we have one. We have two more over here.
Gracias.
Thank you very much. I'm from Ecuador, and I would like to focus on the city of Rio de Janeiro. How did you manage for citizens to understand that primary health is the most important issue? Because in Ecuador we have a challenge that is our citizens, when they think about health or when they have a health condition, they usually think about the hospital. And we, as we said, everyone knows what, but now we have to think about how, the implementation. And I think an important aspect of that is the awareness of the citizens about the primary health system, because they believe that the primary health does not solve their problems. And in Brazil, I would like to know from the experience in Brazil, how did you reach that from the point of view of the citizen? I think we have another question over there. Hello, good morning. I would like to thank all of our speakers. I am Ligia. I'm from the state of Goiás here in Brazil, and I'm a primary health manager. And I would like to ask the municipal secretary here of Rio to comment on this success story, especially on the monitoring of pregnant women. In Goiás, we have been carrying out such work. In Goiás, we have the highest maternal mortality rate of the country, and that is because of our prenatal care quality. And so I would like to learn more about this panel, of the monitoring panel. How long has it been running, and the rates, especially the neonatal component in the monitoring, please. Okay, we have one last question, and then we will all be able to answer them and comment. Good morning, everyone. I have a short question to the representative of Panama. In your presentation, you focused on telemedicine and telehealth in order to make access easier to PHC. And I would like to know, how can we take telemedicine and digitization to the most remote zones and regions? Okay, so that would be our last question, and I would like to invite all of you to answer or comment, even if you were not named by in the questions, because I believe that everyone has some comment on the issues presented. Maybe I could begin, and then we end with the minister, if you think that's okay. Okay, I think the pregnant women monitoring is something quite simple that we've built, especially with the ability of young people to create programs. We were able to do this very quickly, and we were able to integrate our different systems and databases, and we were able to build this great data lake with all the information, and we extract information from there. Each community agent can see the information and the list of pregnant women quite easily. And so I think it's worth learning about it and seeing it. Regarding mental health, we have a very critical and challenging situation, especially with the use of drugs like crack and the autism spectrum as well. Also, our suicide rates are increasing in Rio. So we've implemented planning in order to intervene, especially regarding the psychosocial care units that we can show you. And regarding the issue of how we were able to raise awareness on the importance of primary health, first of all, we had to present that to the politicians, because what can gain more votes is primary health care, because politicians only see votes and money. I know here in Rio, at least, we have many politicians that are very concerned with votes, a few with money as well. And primary health, when done properly and when it solves the problems, it brings many votes to the politician. So if you are to be well evaluated as a politician, you will build a solid primary health care system. So your popularity will increase, but it falls if the satisfaction with that healthcare unit also diminishes. So if you want people to have longer lives and live better, you should build primary healthcare units. But primary health care must be done properly, with quality, and for viewing the solution. If it's something done improvised, without this person-to-person bond, without the individuality, without the digitization, or without coordination of care, forget it, it won't work. And many people say primary health does not solve our problem, it's not recognized, it doesn't bring new votes because it's not done properly. They say they build a primary health care system, but then the person arrives and there's no team. They're treated by whoever's on call. They don't have the list of people that are being monitored. So that is why our strategy was to show our politicians that if they want votes, they have to have a primary health care system that is placed in properly. You can ask President Lula how many votes he gained from the More Doctors or Mais Médicos system, because what really makes a difference in people's lives is primary health. It's the person who was followed by a family physician, the woman who did the prenatal treatment, the planon, which is the monitoring and the prenatal care, makes the difference, because everyone wants to be cared for and decide when they want to have children and be healthy. And so our view is that what impacts people's life is what brings votes to the politicians, and primary health impacts greatly. Okay, for the answering the question about telemedicine, in Panama we have projects that are being carried out in order to give coverage to all the health centers and schools, so that we can have coverage on all remote regions.
Just to add a comment to the fact of access to mental health in Brazil, we've been working since we had this psychiatric reform in Brazil. So we have mental health is linked to the teams that also act in primary health care. They must also take care of mental health. I can't have a family nurse or a family doctor at PHC in Brazil that cannot deal with the main problems that our population presents. It's not only hypertension and diabetes. You have anxiety problems, we have depression, mild and moderate. It's very frequent, and those professionals of primary health care deal with these situations and control them and create a bond. Of course, we need support. We need support from other professionals and share this care. And we have an enormous network of centers of psychosocial units. They are intermediary units between hospital care and daily care. So these people, when they need, they can be hospitalized, but we come back to primary health care, a responsible one. The moment you need support, then you are alerted to that. But we have those centers, psychosocial ones. We have been investing in those, and we want to broaden this access to mental health, not only in psychotherapy, but also in diagnosis, supported by PHC investing in telehealth. We need to potentialize the quality of our professionals so that professionals that deal with primary health care can also deal with mental health. And they must be trained in those tools that can give the population in mental health, because the demand for healthcare, mental health care, is now increasing.
This is perhaps the greatest challenge we face in our country, because it's not just providing treatment. The society looks at mental health not as an illness, but as something that family members shun. And attacking the broadening issue of mental health begins in the school. There's a program we're about to start of identifying bullying at an early stage and encouraging teachers to recognize it. But even more practically, my personal aim is to close what we call the mental health center, because it is just a holding cell. The concept we're going to push is to have mental health dealt with at all our access to health care. We do not believe that it makes sense to just put people in an institution where they're literally held and not treated. So we're looking to revolutionize the whole concept of mental health treatment.
In Bolivia, we have started a month ago to work in a program where integrate different actors, not only healthcare people, the police from Bolivia, and those also who are in charge of governing, but also at the schools. We have a program with different aspects between health and education. One is what the Minister of Education said, is the use of tablets and cellular phones during classes. They can't use it, so that we don't start children being addicted to the screen. So we want to emphasize socializing amongst children. And we also have systems of nutrition at the schools. We have a program that goes against malnutrition with a good lunch for the children, a healthy one. And that's how we face that. In terms of telehealth, we have 84 centers, but we are changing. We want to extend those points at hospitals of the second and third level, where an expert can answer the different questions that those who work with primary health care have. So they can refer patients better. If they must go to a hospital, it can be so the problem can be solved locally. And we work with prevention. That's the name of the game. We agree with the Ministry of Panama that the problem is that we have more quantity of cases of cancer, mainly colon cancer, and we have more renal chronic diseases also, and we end up having hemodialysis. And we in public health must focus in prevention. It's very important to emphasize that. I think that this plenary was trying not only to address each one of the cases of each one of the participants of the panel, but also start a dialogue. That I think we were successful in doing that with your questions that were very pertinent to what we said. And now we are opening a door to all the other subjects we are going to deal with in those 3 days. Telemedicine, networks, comprehensive ones, integration of systems. I think that we need a hand of applause. Thank you for your participation.
Neste momento,
Now, we are going to start parallel sessions in this event. We are going to be in 3 different rooms. Here, we are going to talk about 2 years of the Alliance. Then we have 2 panels, management models and 417 social participation in the transformation of health systems. And the other rooms are not very big. If they are too full, please go to the other panels. And we have simultaneous translation in the other rooms. If you are in the auditorium, you don't have to change your devices, translation devices. Now we are going to start panel number 1. The moderator is going to be the Executive Secretary of the Mr. Adriano Massuda from the Ministry of Health in Brazil.
convidamos as seguintes autoridades ao palco. O moderador da mesa...
Aqui a gente continua.
A subdiretora da Organização Pan-Americana da Saúde, a senhora Rhonda Seeley Thomas. O vice-ministro de Saúde do Panamá, o senhor Manuel Zambrano. A vice-ministra de Saúde da República Dominicana, senhora Yudelka Batista. O chefe de gabinete do Ministério da Saúde do Paraguai, o senhor Juan Estigarribia. O representante do Banco Mundial, o senhor Jaime Saavedra. E o representante do Banco Interamericano de Desenvolvimento, o senhor Javier Guzmán. Hola.
Pedro está tomando fotos de nosotros hablando. No sé qué va a hacer con esto.
Gente, bom dia, quase boa tarde.
Good morning, almost good afternoon. I'd like to start our first panel. The theme is 2 years of the Alliance for Primary Healthcare in the Americas. And I'd like to say that it's a pleasure for me to be here. Once again, I have already talked this morning, and I want to repeat. It's a pleasure to be here in the Getúlio Vargas Foundation that tries to put together new policies and public policies for the development of our country. I think that it makes sense because that's the aim of the Alliance. It tries to develop and promote investments and innovation to strengthen primary health care in Brazil and all over the Americas. So it's a pleasure for me as a representative of the Ministry of Health to be here. As we are running late, I would like to say that it's a pleasure to receive Eudeuca Batista, Vice Deputy, all the members of the panel. It's a pleasure to have you here. So I'd like to say it's a pleasure to have Mr. James Fitzgerald also here with us because he's the leader of this agenda in PAHO. I think that what James said and also the previous panel talked about what is important for primary health care in the Americas and the challenges we have. We have reformed the health care system since the 80s in the Americas and also in Brazil. And it was important for the reform of our unified health system. And then this alliance was a big strength that expanded our own system in Brazil. We improved a lot in terms of building a new model of family health that thinks about having multi-professional teams that are responsible for one area based on the experience of Rio de Janeiro. It's important to see how the fact that we implemented those teams based on the same principles of this access and longitudinality, horizontality, is important to consolidate a model that has important pillars. Mr. James also provoked us, saying that in spite the fact that we have advanced a lot, there was some stagnation in terms of the growth of number of teams and also a stagnation in terms of producing solutions to the new challenges that the system has in front of it. Challenges as to mental health as someone asked, and also the difference in the epidemiological profile of our patients. Besides diabetes and hypertension, today cancer is one of the major challenges. 2/3 of the diagnoses that we have in Brazil are with staging, advanced staging, instead of people going. So besides epidemiological changes, we have had environmental changes. And so our health social crisis also. So we cannot think about a PHC that is not linked to the region, to the territory where the teams work. So those challenges are real. We face them. We have seen them in Brazil. And we saw the effect of, for instance, fiscal policies that are very more, we don't have the same money or the same budget. And so our vaccinal cover has been decreased. And also with the last government, right-wing government, that also decreased the budget in the health area. Now, President Lula's government that really invested in the priority, not only talking the talk, but also walking the walk with innovation and real money. So those challenges are in the agenda of all our countries, and those challenges in those last 2 years of the alliance, we see countries having different strategies to deal with these issues. So my question to each one of the panelists is, looking at those last 2 years of the alliance, what are the advances you have seen and you have identified, and what are the challenges? How has your country dealt with those challenges? And were you influenced by the guidelines from the alliance? Have you changed your model of financing and also of healthcare in general? And what are the priorities and the challenges that you see as a perspective in the work of the alliance around the primary healthcare in the Americas? I would like to start.
Representatives, I would like to greet each of the representatives of other organizations and the academia. It's a pleasure to share this panel with my colleague, the Deputy Minister of Panama, and all the multilateral organizations, and Mr. Jaime and Mr. Javier. The Dominican Republic has had a political impulse that is thanks to that I identify with the Secretariat when he talked about the political will and political decision. If without political will, we would not be able to impact the healthcare systems in the lower levels in order to become the most important part of primary health care. In this time of articulation, we've learned that articulation is fundamental. To articulate, to have engagement is crucial. The Ministry of Health has a leadership role as a public manager and promoting the healthcare system as a provider. Technical decisions that are made have been based on information and have allowed to us to make it a reality when providing the service. But I must mention that in this panel with the correct articulation, we also counted on PAHO for its technical guidance and tools, which allow us to have a guideline for decisions that are made, the roles of each actor and their goals. Lessons learned are that we must mention that spaces as this technical roundtable that we have work based on real will and commitment, and about the real role of primary health as the core of healthcare system. Also, international cooperation must be aligned with the reality of countries are crucial. The permanent dialogue that must be translated into results is also important. So correct articulation, clear rules, and political leadership are key factors. In summary, when we have a dialogue that articulates with political will and institutions, it becomes results. Thank you.
Representante, então, do Panamá.
Muchísimas gracias.
Oh, thank you very much. Once again, I would like to thank PAHO, the World Bank, and the Inter-American Bank that have been helping us as allies in what we are trying to develop in our country to improve the primary health care in Panama. In the Ministry of Health, we have a consultative group for primary health care, not only as a space or a place for dialogue, but is an operation mechanism so that we can align the national priorities, technical cooperation, and the agenda of investments. In this sense, the national health policy has been developed for many years with the technical support of the Pan American, the PAHO, and it works as a landmark for the technical cooperation and of investments of both the World Bank and the Inter-American Bank. Based on the consultative group, we have main strategies: integration of the Minister of Health and also the monies that come from Social Security, digital information in health, and the information about transmitted diseases, so that we have just one route nationally speaking. And we define what are the strategies that we will use in the health area in 2530. This strategical national plan to eliminate transmittable diseases in 2523, and also for colon cancer, those for 0 deaths due to uterine cancer in 2029. According to those priorities, this group, this board, facilitates a coordinated work that will allow financial and technical cooperation that's going to use tools validated by international peers, so that we are not redundant, and we have a real support that is effective. Through the alliance and the priorities that were defined by the board for PHC, we were able to orient or to guide investments of short range, medium range, and long range. So we have invested in the critical areas to strengthen our healthcare system. Those investments are followed by technical assistance that also incorporates planning in the medium and long run. So with that, we can assure that those objectives are met and we have the impact that we hope for. A concrete example of digital transformation where PAHO, the World Bank, and the Inter-American Bank for Development have acted complementing one another. They have strengthened the personnel of health and also telemedicine and the interoperability of all the systems. Panama sees the alliance and the consulting board as a platform of efficiency. They maximize the impact of each dollar that is invested, and so it strengthens also the trust in the state and its partners. Thank you very much.
Thank you, Manuel. Now I'd like to pass the floor to Mr. Juan Isargabia, who's the Chief of Staff of the Ministry of Health of Paraguay. Thank you very much. Good morning to everyone. I'd like to greet all the authorities that are here present, the Ministers of Health, representatives of international organizations, and my panelist colleagues. I would like to thank PAHO for inviting us to this second regional meeting of the Alliance for Primary Healthcare in the Americas. I convey a message from the Minister of Health of Paraguay, and it is an honor for our country to be able to be here in such a high quality panel. For us, primary health is the core in order to advance towards more equitable and sustainable healthcare systems. Since the beginning, Paraguay has promoted efforts to have the solid governance on the board for primary health care. We fought for its institutionalization as a permanent and sustainable tool transcending political cycles. For the government of Paraguay, primary health care is not just a program or a government project, but a state policy. It is central in order to reach universal health care coverage and reduce inequalities and the proper sanitation system. The trajectory of the healthcare in Paraguay has been on for over 2 decades and working for access and trying to solve problems as gaps and breaches and inequalities. Then since 2008, there was expansion of the family physician program, then focusing on people, families, and communities. Since then, primary health care has been incorporated in a sustainable manner in the strategic plans of the healthcare sector, especially regarding attention and comprehensive care. In the past few years, we have advanced towards a systemic view, recognizing it as the organizing strategy in order to promote quality, human resources, and articulation among the different levels of care. In this framework, the board was emerged as a strategic tool for governance, and it was created not as a situational context, but as a consultation articulation tool aligned to the national priorities of the healthcare system in the ministry. And we reaffirm that this board is not an event or an isolated initiative, but a continuous project that accumulates and advances in order to transcend political cycles and follow the consolidation of primary health as an organizing strategy for the healthcare system. In our most recent meeting of the board in Paraguay in January 2026 reaffirms this continuity because we've continued previous agreements and advanced in our collective discussion for our operational plan for 2026, forming theme roundtables and new challenges, identifying new challenges and creating a more permanent situation. In order to reaffirm its leading role, we have reaffirmed its governance, its technical leadership, and its international cooperation. Our 2026 plan has a very clear structure. The Ministry of Health is leading the situation. The technical table is led by the Primary Healthcare Authority. Also, the PAHO is involved, the IDB, and the World Bank are also included. In this design, we organize responsibilities and technical advancements in face of political changes. And this strengthens the ability of the board to face strategic challenges. The board in Paraguay has a broader view that goes beyond the primary health care unit and sees it as a more cross-cutting system within the whole health care system. And with this, we can integrate our work groups and our roundtables, all the authorities and operational and strategic units from the Ministry of Health with HR, mental health, quality, planning, decentralization, indigenous peoples, surveillance, and institutions are our focus. Also the multilateral banks and PAHO. This broad participation is not just it's not just symbolic, but we can reach real consensus and agendas with this and ensure that primary health is offered in the macro, medium, and lower areas of the system. The Paraguayan board has evolved from a space of discussion into an operational action, which is important for us to ensure the provision of primary health care. In 2026, in the beginning of the year in January, we have decided to create these themed roundtables, identify and establish the leaders of each topic, and work with concrete products and leadership with the view to the 2030 agenda and a specific schedule for 2024 to 2028 as well. With this, we've deepened the work with priority topic access, promoting quality, mental health, HR, care lines, and maternal and child care with results, indicators that make this board a real implementation tool. Primary health care in Paraguay is comprehensive, modern, and systemic. It focuses on people, families, communities, and it articulates within comprehensive networks with a view towards life, quality, health, mental health, chronic diseases, maternal and child health, and digital transformation. The board in Paraguay allows us to operate this vision with political will, financing, institutional abilities, avoiding the fragmentation of efforts, and ensuring results in the whole country. During this process, PAO has had a very important technical role following the design of our governance and regional frameworks, the building of our operational plan 2026, and the facilitation of consensus between different actors. Its participation as an executive secretary reinforces the neutrality and the quality of the consulting board of Paraguay. This board is an institutionalized platform. It's participative and result guided. to ensure governance consensus in order to accelerate the establishment of primary health care as a policy. It also ensures a participation, the broad view of PHC, and the participation of all the members of the alliance and PAHO.
Thank you, Juan. I had the wrong agenda. But now we had our colleagues from the panel. Now we are going to hear from the three institutions that are part of the alliance. I would like to give the floor to Mr. Saavedra, then Mr. Guzman, and last but not least, James Fitzgerald from PAHO. And from the point of view of the institutions, what have you seen from the last 2 years, and how can we strengthen the local countries and their health systems? Thank you. I have to mention 4 points. First of all, I think that the platform of the alliance is good, but it must be much better in the next few years to recognize the magnitude of the problem, because it's great in some countries and smaller in others. It's not easy for a society to understand the patterns or the standards they have to recognize. There are other countries that have the same level of budget, but some are better than others. People have to understand that depending on the system, it's going to have better or worse results. Depending on the country you are born in Latin America, the health service is going to be different. It's not equal for everybody in all countries. This is, unfortunately, the quality of the service that we render. I think that we have to recognize that, because the gap is enormous. And this gap is quality and also education. I'm talking about education, but I'm wrong. I'm talking about health. How can we deal with someone who can't read, for instance? So health and education are linked. People who are a child that is 10 years old can read and understand, but the indicators are different for everybody. Another indicator is how much you expend, the expenditure. It's more countries are centered in hospitals. Let's invest in a hospital. People want more hospital. They demand health. Let's build a hospital. No, this is wrong. We have to prioritize, and that's our challenge. We have to prioritize PHC. But we have an upper one, that is to prioritize health within all the other priorities of the country. It's not the level of this room anymore. It's outside this room. What is the biggest challenge here? All the research we do, what is the most important problem? Is security because of violence, then jobs, then inflation, because people look at education and health also, because the politicians don't answer to all the demands. Some will think about those priorities in the long run for the development of the country. But we have to insist that we have to invest much more in this complex reform, not more resources, more dollars only. We have to make the complicated decisions we have to make in the health area. We know some countries we have to integrate the systems more, don't have different silos. in different systems. We have to integrate. The systems must be interoperative. This is a political decision, not only money. So that's why we have to prioritize the development agenda of the country. So that's why I say those are political, complex political decisions for the system to change. And last, another task for the alliance is information and evidence. The Secretary of Rio mentioned the fact that it's important to use science to make decisions. When there was the COVID problem, we needed science to be sure that all our political decisions were based on science. But there were authorities that did not believe in science. They had different opinions of how to fight the pandemic. So political decisions must be taken based on science. And in the political area, we don't have to look at the Scandinavian countries as models. We have to make our own decisions. Chile, Colombia, Brazil have made the decisions. It's not only in the rich countries. In Latin America, we have examples of things that worked well. Let's look at the countries in Latin America that have already made political decisions that were difficult, but in the end, they worked out. That's how we change mindsets. Thank you.
Thank you very much. It's an honor to share this panel with the representatives of Brazil, the Dominican Republic, Panama, and Paraguay, and our two strategic partners. I believe it is important for us to think about what these 2 years have been about and about what we want for the future. And when we look back at these 2 years, it is important to emphasize the creation of the platform, because it looks like something very simple in which the IDB and the World Bank collaborate, but we know that it hasn't been easy, and it has allowed us to have a stable platform that enables collaboration and interchange and also helps us work. And it is important that it has its regional governance bodies and the local governance bodies. And it is very important for us to value the commitment of the countries in establishing the primary healthcare as a priority, and the consulting boards. We have 3 very good examples here that show us that it is possible when there is a will to work and there is political will. We also have a few public goods that are operated by PAHO that may help us work and to recreate this in each country. And when we look towards the future, what I believe is most important is that the alliance must help us take this work from how do we want to measure the advances in primary health. And also we have to define priorities. We have to define how we're going to do it. We have to define how we're going to measure and report, because that is crucial to the success in the future. And I think that the Alliance has 3 levels of work. The first one is the collaboration among countries and to present the importance of primary health care for the government and societies. The second is the collaboration between countries, how each country works and how we can strengthen ourselves and interchange and exchange experiences. And the third is the regional level. How can we elevate the discourse on our local and regional levels, and how we can improve the strategy and this action plan in primary health care in the future. So at the moment, I believe we are at this very important moment where we have the commitment, we have the partners, and now we have to move on and do things. We have to define clear objectives and goals and to start working on them. Thank you very much. Thank you very much. And I wanted to thank everyone that is here present and also congratulate you on the work, because you're showing us how things are done, how they are done on the national level, the leadership process, also on the subnational levels with the Ministry of Health, in order to structure that will lead us to the consulting board under the priorities of each country, and also the leading countries, and to make it effective. So I would like to congratulate all of you for the work you've been carrying out, and all others that have been building these boards. Just a little story. Our starting point was the pandemic, in which we worked together with the IDB and PAHO and the World Bank, supporting countries in reprogramming finance and credit for and grants to reorganize new courses in order to extend the response in face of the pandemic. And when this critical phase ended, the three organizations sat to discuss and think, okay, what do we do now? What can we do now based on this very positive experience, so that we can also help and follow the countries in the future? And the recovery with the we believe that was a focus for all three parties, and this is something that we decided that we must take advantage of that moment in order to support countries in the recovery process, not only recovery but also development later on, regarding the sustainable goals, the sustainable development goals of the UN. That's when we went to Uruguay and we launched the alliance with the participation of the countries. And at that moment, we chose three pillars for the alliance, which were the investment and the challenges that we still face in relation to the post-pandemic context. And we spoke about that in the beginning, this morning, about the financial situation, and the fact that we have actors working with the countries in finance and credit, but also in health, that are able to mobilize the national resources through these mechanisms and agreements. And we chose these 5 countries that have the consulting boards, then have agreements with the banks for over $1 billion for healthcare. So we know that they are not in the budget. They are not resources that are in the budget, but they are very important for the transformation process that the healthcare systems were under. And the second topic was innovation. What can we learn with the pandemic? What can we do now in order to take these lessons learned and scale them up, applying innovation in digital health and services providing and training of human resources, and how can we use them to identify our action axis? So this is also a very important area. And the third point is the effective implementation. As 3 partners, how can we help countries jointly under the priorities of each state? How can we support each country for their coordinated implementation and to implement their future actions? And what we've seen here with these 3 countries, we can see that things are working, but we still face many challenges. The organizations are different with different mandates, but we have learned that we are stronger together, and together under the leadership of the country. So the country tells us what their priorities are, and we allocate the resources, and we have an integrated and comprehensive planning. And that, I think, is the real value of this alliance. We would like to invite other countries to explore and advance and identify the opportunities to integrate the alliance. and advance on this topic. Thank you very much.
Thank you, all of you who have spoken. I think we heard some things very important about the individual countries and the institutions. We are running late, but I would like to open the floor to the audience. Our friend Francisco Campos from the University of Minas Gerais, because I think there is an axis missing, which is training or education. How can we align investment, education with implementation? But we have to invest in training the professionals, those who already have graduated, but mostly those who are still at in the academic world. From the Brazilian experience, we say that we have 70% of the population is covered by the family health program, but they are totally different. So we need different trainings to deal not only with the daily problems, but with new challenges in the technological area. People need to study, to be trained, and that's something I think we have to plan for, because the continent is very heterogeneous. Thank you. Before I asked for the floor, I wanted to talk. I'm going to be brief. First of all, I would like to talk about an experience, because I was in the Global Health Workforce Alliance. I represented Latin America. I would like to tell you how another alliance could help in what I wish for this alliance, for its success. From 2006 to 2016, it was called Global Alliance for Workforce and Health. And lots of resources were mobilized. And we knew at that time that the main problem was the lack of health professionals. So at that time, I was with James in Washington. We talked about that. Both our colleagues said that I was the only representative of the Latin America region at this global initiative. We had lots of financing. You remember that USAID was still helping us. We had money from IDB, we had from Norway, from Sweden, from Canada, from the UK, from France, from the World Bank. And we thought a lot about how we could avoid a problem that is the migration of professionals that come from Africa and the Caribbean, but they don't stay there. They come to other countries. So I think that this is something very important. How do you come from the what to the how, to the policies de facto? I think that if one alliance can help the other with lessons learned, with failures and successes, I think it's very important, this movement of creating a consensus, of creating a discussion. The Global Alliance there was a global forum in Kampala of human resources, another one in Bangkok, another one in the city of Recife in Brazil, with the Minister of Health Padilha in Brazil. But I think, well, some things happened. There was an ethical code of recruiting people being approved by the World Health Organization, the WHO. Task shifting also was an issue. Many countries allow for that. The scale up also of the training for health professionals. But I believe that if you don't have this cooperation South-South that you are doing here, one looking at the other's experience and getting to know more and go forward, having this new knowledge, I think it's very interesting. That was my first point, meaning what the Global Alliance for Health and Workforce could help this alliance that has been on for 2 years, and I wish you all the success in the world. Now, I work for the Open University of the Unified Health System of Brazil. And Brazil now is looking at that issue or those issues with integration. The integration is in the Brazilian Constitution, saying that SUS mandates the training of human resources. So we have to integrate the world of health with the world of education. The Open University of SUS and PAHO even the WHO has important initiatives in this area. But to implement PHC, at that time, if in Brazil we only did the medical residence, the traditional one, we would take 160 years to have these doctors. Now we have 20,000 professionals studying to be experts via distance education. They are the same thing as a residence in presence, face-to-face. You can use distance education, you can use this technology to graduate professionals. So we have a group of 13 million workers, health.
Ask a question, but I'm going to speak Spanish. I'm going to speak Spanish because it's the language that most people speak here. So I began my work 2 months in El Salvador, and the experience has been very interesting, and it's interesting to see the experiences of other countries, and also the thoughts of our partners in the alliance. But even beyond the technical consensus that are very important for planning the governance and that is led by the national leadership to advance these national and regional public goods that may be used by all in a more harmonious or aligned way, could imply, such as Dr. Campos has mentioned, maybe it implies a need for adjustments, not only in budgets, country budgets, but maybe adjustments in the technical documents from the banks, in particular in order to address interventions that are softer, let's say, as training or specializations or technical assistance, because the impression I have is that maybe there is this margin in a few projects by IDB and the World Bank in the country budgets. Maybe there's a margin for a better prioritization and adjustment of these public goods that are not only bricks, cement, and team for building, but as Brazil shows us, as important as that is to invest in training, capacity building, that maybe costs more than what is in the budget at the present moment. Thank you, Julio. Armando?
I'm going to speak Spanish too. I represent PAHO in Venezuela. I'm very much concerned about the difference in the concept of primary health care. Sometimes I think we are talking about these services of community service as if it were healthcare, primary health care. And I think this idea is dangerous because it reduces the complexity of primary health care. If it is a strategy, then we have a problem. All the components of those systems of health in our countries are not sufficient. The number of teams that we have for community health and family health care are not sufficient. And also, we don't have the number of beds that we need. This doesn't depend if we have budgets, but it's a scale problem, the supply and demand. If you compare the number of beds in our countries compared with other countries of OCDE that have more specialized services, the number of our beds is 1/3 only. So to strengthen, first of all, the community health doesn't solve the problem of people going to hospitals. And this is something that concerns me. If we want to strengthen the services of community health, we cannot criticize the hospitals or the hospitalized, centralized hospital system. What is bad for the money is for those people who need hospitalization. I don't want to talk about that for a long time, but I agree that PHC or essential care would be the best than primary care, but essential care should be understood in more depth because it's the totality of the system. So we have to expand our activity. It's primary health care and hospital care also. If the hospitals have a focus on primary health care, then this would be important for the healthcare system. So I believe that we should debate more because I want to form, to train and graduate surgeons with PHC, not only those who go to the community and then they need a surgeon and you don't have enough surgeons. So this is what I wanted to say because I think that this alliance would be stronger if you add to your discourse this issue. And the workforce is also a critical subject because we have professional migrations in all continents. It's difficult to hire good professionals, and also of privatization over the capacity of the public systems. We have to defend that, the public health systems. And we have an enormous fragmentation also. Many institutions are within the same field, but they do not coordinate. Systems that depend on social security and other systems that are supported by taxes. So we have to think about that. I think that this is part of the exercise that we are doing here. We have to create this space for discussion so that we can fine-tune our ideas. I have time just for one more question, and then we'll go to the answers. Good morning. I am from Pajo in Bolivia. We would like to thank for the comments of the panelists, and I have two questions. First, the issue of political will, because this is very important. The political will, locally speaking, this will generate an impact. How can they generate an impact? This is the first question. The other is we have an operative framework, and we have to monitor that. How can you monitor what has been implemented in this project so that you can use the lessons learned? Because we are all going this way. We are all going through this path. So thank you. Thank you for your questions, for the audience who has participated. So I'm going to start with James in your answers for your final considerations. Thank you, Adriano, and all of you who have made comments and asked questions from all the different countries. We have 2 years of experience, but we have more years of connection with the countries. And we have to consolidate the mechanisms and identify priorities, as has been said. The issue of human resources is something that we always talk about. No.
And we have had a few discussions on this topic with our partners to see how we can advance on these challenges that we are still facing and that were aggravated with the pandemic and migration towards the north. But it is complex because when we talk about jobs and work conditions and training contracts and multi-professional teams and control flows and processes is very difficult. But we must do this because we must take this to the board of Pajo and then later incorporate the labor department and the education department to our board. And this has been very interesting to begin this kind of work. And as Pajo, I think we're all in agreement. We have a very clear strategy. We presented it this morning, and we will continue to support countries in implementing this strategy and also in sharing all the experiences from each country so that countries can learn from the experiences of other countries and improve the experiences. As I said before, we cannot do this alone. We must work together in an integrated way. Thank you very much.
Thank you very much for your questions and your comments. First, it's important to learn from other alliances. Of course, we can benefit from that. And secondly, it's what we are doing in the banks to change our operations to reflect the priorities of PHC. One of the things, we are institutions that give answers to the countries. We are under their governance. All the countries are different from each other. In Central America, for instance, we have a problem with infrastructure. And the infrastructure, when it arrives, there is a lack of numbers per inhabitant. So we have to start talking about infrastructure that we can change it, and then we have better services. So we don't need only infrastructure, we need also primary health care. So we have to enter into a dialogue with the countries in different ways, depending on the situation of each country. And our response has to do with which each country demands from us. And the quality of the service, we can also improve the financial sustainability, the quality of the institutions. Of course, we can do that. And the third point is that the fact of human resources and talents in healthcare, we have this enormous challenge with immigration and also training. It's an enormous task. The countries demand that. The countries from South America and Central America can train professionals. In the Caribbean region, there is a migration of professionals, a brain drain of professionals to Europe. Most of the doctors go to Europe. We have a demand, and the governments want to for us to train human talent. And I think that it's important to talk to Jaime. Many times the decision making in the health area is not done in the area of health, but in the area of education. I'm from Colombia, and we want to expand the training of professionals with the third layer hospitals. So I believe that this interaction between the education and the health ministries is very important. And it's something that where we could focus our attention. And finally, I think that as to monitoring, our operations have a good system of monitoring. We report our indicators of each operation. And there is another way of thinking, that those monitoring systems are not integrated with the monitoring system of our partner, the World Bank or PAHO, or of the countries themselves. So it's important to have that. I think it would gain a lot if we align these monitoring systems with all the institutions and all the countries. Thank you.
Thank you very much. And I would like to begin by going back to the human resources topic, because in Guyana this was a very important issue. We had this training center. It was an education project. It wasn't a health project. And it's true that if on the one hand we have the need for a comprehensive view of HR, which focuses not only on the career but in the training of the health professionals. But we also have a balance problems because in some countries the training for professionals in health is more attractive than for the general physicians and health practitioners. And also in Latin America, we have more qualified nursing schools, and well, we have a lot of work to do with regards to HR, but it's also related to the job agenda, because all governments have the agenda to create more jobs. And differently from other social areas, the health sector is one that needs more professionals, and also with better quality, and are better allocated in the whole territory. But also you need a larger number of people. And so the work that all members of the alliance should carry out is to make this topic more visible. And also, Dr. Campos was talking about the balance point, and I think that this emphasis on primary health care, to give so much focus on this when we have gaps in other areas, maybe I think we're overemphasizing PHC as if other healthcare issues were already resolved, but they are not. So sometimes in the discourse we tend to go to the extremes, like in the political discourse, when we say we must build these hospitals. Yes, no, we must build primary health care units. We have to focus on PHC as if it was an articulator of the whole system. However, we still have many gaps in the other sectors of the healthcare system, like, for example, cancer care units. Like in Brazil, we have a lot of work to do there for oncology. But of course, we cannot think that we have to solve primary health care problems and then everything will be resolved. No, we have to advance on all fronts. But it is true that the PHC has been abandoned in many of our countries, unfortunately. And as someone also mentioned on public goods that must be adapted to the reality of each country, is true, because these are produced with regional knowledge in order to inform the decision-making process. But those that are guiding the process and the decision-making and priorities are the authorities of each country, and ourselves as alliance or international organizations, we are here to follow the priorities that are established by each country. Sometimes we wish these priorities were different, but it's the country that decides. And it's the country that must decide its priorities in all topics and how they prioritize health in comparison with other topics, and how they prioritize the different demands within the health issue. Because everything that we do is to inform the decision-making process on the national level, and the governments and the multilateral organizations. We are here to support you, and for this support to be more comprehensive and integrated and coordinated. And I think that is our positive role.
Thank you very much for your comments and your questions. I'm cold. I come from the Caribbean, so I think it's very cold. Well, different from Brazil, we are in a transformation process where primary health care is the center. This led us to do some prognosis and rethink the organization of our system. I agree with you that human resources are very important. We have just published the first census in our country for health professionals. We identified what we lack. We all have the problem of migration also. Many of our professionals go to Europe, but in terms of health, this affects us very much. In the case of Italy, for instance, people from the Dominican Republic go a lot to Italy. So human resources, we need more nurses and more nurses helpers. In Italy, many of our professionals go to Italy. And the Italians take our nurses, and as our salaries are lower, they are very much attracted to moving to Italy. As to the investments, we have an important gap. As for infrastructure, the number of that we need, it's $2 million of monies or investment that we demand to have a better primary health care in our country. So we have programs with the World Bank and the IDB to generate policies and strategies. In the second phase that we have is to reduce mother-child mortality. As to the training of human resources, I'm not talking only about the professional training, but to improve the capacity of those that we already have working at the institutional level. It's an expectation that we have to identify a policy that will foster human resources to have a better training and capacity building. To integrate politically the community is not difficult. In our case, the government party is the majority, but it's difficult when we have a consultation, the public consultation. We have to integrate that to the governance, to the senators and the people's representatives. And when we have a project of primary health care, it's not well received. And the discussion is where it should be, which province, which state, and not the need that we have for that. So the discussion is all wrong. Thank you.
In Paraguay, we have been working for 3 governments with national policies. One of them is the policy for health HR, in which we have a strategic policy for HR that is based on cooperation. And we have several studies regarding gaps and the demands for professional training in the country. Last year, we had a very important and interesting experience in which we declared and we carried out what we call journeys within the week of health professionals in Paraguay. And we carried out workshops and journeys for the health sector, but also the educational sector, for which the ministry is also engaging other actors so that this becomes a national health policy. And so if all of this, all the other countries have expressed their policies. In Paraguay, we have something that benefits us, which is that the Paraguayans are very connected to the country and they don't leave it easily. So that is something that benefits us and leads to better work conditions for our workers and better economic context and situation that we are planning and implementing in process to benefit also the healthcare professionals. Today we are also building the health and sanitary career that involves not only the healthcare professionals, but also the administrative professionals, because those that manage the system are other actors in the health chain. And on the other hand, everything that is regards health care is that we focus not only in people but also communities, and for that we have a very important tool in that is used that as an incentive tool. It's that's our funds based on health results. That's what it's called. And that is under the management of local boards and regional health boards, in which must reach goals in order to receive these resources. And these must be allocated within the health services. And we are also implemented changes in this community engagement, because we are being it is helping us to prevent diseases. And what we want and what we have as a challenge is that we want to invest in trying, for example, now FOBADIS, the fund is made up and focused on diabetes and high blood pressure, but we want to change that because we want that incentive to also be received, because the population is becoming more healthy or is healthier. So with that will lead to lower costs, and that should be incentivized.
Thank you very much for your question. I absolutely agree with what you said. The problem of training of professions. We have really a gap in this area, a deficit. And we are not, immigration is not such a problem for us, but we have a gap in the area of experts. But I'd like to say that I feel there are two different things. One situation that we have been living with in the last 30 years is the investment in infrastructure, in technology, in mammographs, in MRIs. But the new concept is to pay attention to PHC, is to avoid the disease, is prevention. One doesn't exclude the other. We are finishing building hospitals that have been out of action for 10 or 15 years, and we are finishing those buildings. And all this investment comes with a lack of experts. There is an enormous demand for experts, expert doctors and healthcare professionals. So we need investments in infrastructures. Now that we can solve this problem, and now that we have the infrastructure, now we see that there is a gap in the area of experts. We need them. We lack those experts. So we can think about how to face this situation. We are investing, paralleling, creating infrastructure with equipment, with new technologies, but on the other hand, we have to think about, I'm going to say something that seems like something that I'm a dreamer, but I hope that in 10, 15 years, our hospitals are empty. Our health centers do not have patients. Our clinics don't have enormous queues of people who are waiting to get their medicine. because we will see the consequences in the future, what we are doing now in terms of prevention, so that our patients will avoid having major problems. Cardiovascular problems are our major cause of death. So all of that is a macro idea, but with different points, and we can't exclude one from the other. All those themes have to be together. We have to align them all so that we can improve our health systems. Thank you very much. Thank you very much for the members of our panel from Panama, the Dominican Republic, from Paraguay, from the World Bank, from the IDB, and also from PAHO. The panel was excellent, and I hope we can have a stronger alliance that gets stronger and stronger, so that we can integrate the articulation of investment, education, and so that we can go forward. I hope we can have a third meeting, not in 2 years' time, but next year. Thank you very much.
Neste momento, realizaremos uma pausa para o almoço, retornando às 2 horas da tarde. Tenham um bom almoço.
Vamos a almorzar un poco. Sí, yo quería ir a un pequeño almuerzo ahí afuera.
Senhoras e senhores, boa tarde. Convido vocês a retornarem para o auditório, porque começaremos.
Ladies and gentlemen, please return to your seats in our auditorium because we will begin and resume our schedule shortly.
Señoras y señores,
Ladies and gentlemen, good afternoon. We inform that the planned visit is for ministers, deputy ministers, and foreign authorities, and we ask them to please be at the foyer of the cultural center next to the flags at 4 p.m. to be able to do the transfer for the visit. And now, resuming our program, we will begin our panel, Digital Transformation and Primary Health, Opportunities and Next Steps. This panel is divided in two moments. In the first block, international cooperation, we would like to invite the following authorities. Our moderator is the head of the IT information systems of PAHO, Mr. Marcelo D'Agostino. The head of the Health Division, Nutrition and Population of the IDB, Mr. Javier Guzman. The Manager for Health, Nutrition and Population of the World Bank, Mr. Mikhail Granolakti. And the Director of Evidence and Intelligence for Health Actions of the of PAHO, Mr. Sebastián García Sainz. Good afternoon, everyone. It's a pleasure to be here and sharing this panel with my speakers, and I will later mention their roles. I was going to try to speak something between Spanish and Portuguese, but because we have interpretation, I will speak Spanish. I would like to thank, as everyone has already done, but I would like to thank the Brazilian government, the Brazilian people for their warm welcoming, but also for everything that they've been doing in the information area, the exchange of knowledge and projects in collaboration with the other countries in the continent. Brazil has always been an example, and it is not a coincidence that we are here today with this panel regarding digital health, artificial intelligence, telehealth, which were topics during the G20 meetings, also at COP30. They were topics addressed, and at every meeting, this high-level meetings, Brazil has put forward these topics due to their experience of decades. And I would like to mention Dr. Ana Stella Haddad, who heads one of these IT departments and has advanced in these topics, and we have been working together for many years. I would also like to highlight something that is very important to me, which is the presence of Mr. Francisco Campos, Francisco Chico. He is a legend in the Brazilian health system, and I emphasize him because he was one of the great mentors and creators of initiatives that today are working, as is the PAHO Virtual Campus, which was created with his guidance. And so thank you, Dr. Campos, for being here with us. It's an honor to have you. And a little bit, I will be brief. Today we are talking about digital transformation. It's something that's been going on for many years. We have discussed the e-health concept and other topics and about the digital transformation in the health sector. And we celebrate all of this, and we have spoken with Dr. Ana Stella Haddad during the closing session of the G20 for us to try to not lose this momentum. And that is why it's so important for us to be here with these three organizations so that this becomes a permanent topic, because technology and telemedicine, including artificial intelligence, are nothing new. They've been around for over 20 years. But in reality, we needed a pandemic for these topics to reach a certain level. And we've always heard that telemedicine is something innovative, but it could have been implemented 20 years ago, but we have only done this as of the pandemic, and we've been discussing this with other institutions. I would like to highlight the partnership we have with for in digital and technological topics. And for that, I would like to thank the World Bank for being here. Well, I will now would like to connect this panel with the following panel, because not everyone knows how we, the international organizations, work regarding technical cooperation with each country. Many people also do not know about how we are integrated regarding digital health, which is our topic in this panel. So I would really like to talk about this so everyone learns about the organizations, how they work, and how we work together. And after that, we'll have a next panel with authorities from 4 countries to put your feet on the ground, because sometimes what we have is very broad and great visions. We must ensure that they strengthen the health agenda of each country, and that we do not impose anything to the countries. And that is our mantra, our slogan. So to have one agenda, which is the agenda of the countries. Today I have Sebastián García Cinzón, head of the Department of Evidence of PAHO, which is one of the units that I also head, which is for digital health. We also Mr. Javier Gurman, head of the Population Nutrition and Health of the IDB, who also coordinates this very broad unit on digital health. And I would also like to thank Dr. Jennifer Hernando, who is following us online, and Michele Legrano Gratti, head of Nutrition, Health, and Population for Latin America and the Caribbean of the World Bank. And I would also like to greet Jean-Luc and Frederica, who are connected with us online. As a first question, I would like to ask all speakers to speak for 7 to 9 minutes, and we'll have after that a second round of questions. So the first question goes to Sebastián. Considering the vision and mandates that governments have approved for PAHO in the directive board, specifically regarding IT and the digital transformation, would you please tell us what are the priorities of PAHO to accelerate this process? Something James has already mentioned earlier today, the importance of speeding this up. And what is the expected impact in the region? Please.
Thank you, Marcelo. Good afternoon, everybody. It's a pleasure to be in Brazil and in Rio and be able to work in such an important forum. The mandates of OPAS, PAHO, are tools for us to share as countries that are part of this alliance, so that we can set our priorities and say how we can strengthen our systems of information. This, in the framework of PHC, are the instruments, the basic instruments that we are talking, not only about an separated use of technology, but we are building the landmarks that allow us to be more efficient and more sustainable in primary health care to meet the demands of the different populations in our area. So this agenda of digital transformation, the countries have prioritized a different route in the area of primary health care with 8 principles. There is an action plan in the information system that leads us up to 2030 with the different issues to be approached. It's an agenda also that talks about the data and the use of AI so that we can generate better information, better analysis, and then this will lead to better decision making. This is an enormous agenda that unites all the countries, and I'm going to highlight 6 central priorities. The first of all is governance. It's one of the landmarks that guides us to establish the priorities, the actors that should work and share this workload so that we can establish a strategical agenda of digital transformation. So we have governance of data, also security of data, ethical aspects of the agenda, and the use of AI. In this agenda of governance, we also include an alignment that is very important for the different sectors. So it's an intersectorial transformation process. So it's the relationship between finance, education, health, and other actors that will allow us to introduce a digital agenda that is not something separated, but is linked to the government agenda of the state, so that we can have a sustainable financing, so that we can change the inside of our institutions, so that we can count on the telecommunications sector, that is one of the vectors of transformation, connectivity. So health is not in a void. Everything has to be connected. And so we have to take into consideration that without governance and financing and investment in digital transformation, nothing will happen, and we won't have the return that we hope for. The second point of priorities is interoperability, an architecture, a national one, that will allow us to go from a fragmented system that we have in the area of information, where we have quality information when we need it, so that we can make the right decisions in the area of health. So we have to connect the silos. We must have platforms that are interconnected and not isolated as they are currently. So we must have integrated comprehensive systems where all the information gets together, so that we can make decisions at the national and international level. And this implies accelerated in standardization. The standards, we all know, we have to generate an architecture that will connect programs and institutions, that will allow the fact that we have primary health care that is strong and available to all. Laboratories, pharmacies, hospitals, they all should be connected. We have to prioritize also the quality of data. It is fundamental, it is critical to have good data. So we have to strengthen interoperability so that we have digital public goods as a priority. We have shared platforms where we have a focus that help us to avoid problems, so that we can contribute to the development or of platforms that are available to all the countries that are part of the alliance. Third point is quality data, so that we can make the right decisions, the ones that are needed. We all agree that if we don't have data or intelligence in the area of health, the decision-making process is not going to be the right one. So this is a major priority, to integrate information, the surveillance systems, statistics, data, so that we have a good model of health intelligence to support decision-making at the national level. The fourth point are the digital services centered on people, so that we can strengthen primary health care. Telehealth is a bigger concept than only teleconsulting. So it's a link amongst health professionals, and they are in contact permanently with the health system and the community services of health, so we can have a better health care. And this also leads us to generate technical designs, and we must have digital knowledge that is not only linked to the development of new technologies, but the need to generate a permanent link. The next point has to do with the workforce. A workforce and management of those human resources. So the management of change is critical. It's a regional priority. And we have more than 10,000 people that are in capacity training, and they are also acquiring expertise in the area, in the digital area, most importantly in AI, but also in other technological areas. So we have to redesign the clinical processes. We're not only integrating digital tools to processes that will take years to exist. We are thinking about a new architecture for public health and for our services. How can we change them? And the last point, it is the artificial intelligence. It's not something that started a few years ago. Now we have a boom of visibility of AI, but it's been around for more than a decade. So we have to prioritize the integration of tools that will allow us to use that in primary health care, for triage, for laboratories, clinical laboratories, hospitals, and at the same time we have to ensure transparency, evaluation, and an ethical landmark that must be clear and very strong. So we want to make an impact that will allow us to have a better access to healthcare, primary healthcare that has more digital mechanisms that will improve our response to the challenges that we have, like epidemiological challenges, reducing inequalities, and more transparency also to our systems. Those are our mandates. Those are very concrete actions with the prioritization of those technical specific points. And we share that with our partners, especially the banks that are our partners, the IDB and the World Bank. So we must prioritize primary health care. Thank you very much.
Thank you very much. Now I would like to ask a question to our colleague Javier Guzman, head of the Division of Health, Nutrition and Population. From the point of view of BEAD and considering the strong partnership that we have in information systems and digital health. It would be interesting if you could please share what are the main projects that IDB will be promoting in 2026 to ensure that actions and investments in digital health are sustainable and that also have the expected impact on the primary health systems. And thank you for your partnership. Thank you, Marcelo. I think that it is important to emphasize the cooperation between PAHO and the IDB on this topic. We have several other topics that we collaborate, but this is one of the most important because we have a very clear goal, which is to connect all these tools that are fragmented within the countries and between countries. And our most important expectation for 2026 is to continue operationalizing the Pan-American route for digital health, which is a concept that is very ambitious and very powerful. If we recall that 100 years ago, we did not have an infrastructure connection between in the region, and if we think about how we can connect the continent, this is a route, the digital route, that I can take knowledge from health from one country to the other, or maybe the health background of a person can also travel from one country to the other, and the limit is our imagination. And we have seen many important advancements last year. The Americas was the first region to issue yellow fever certificates. In Costa Rica and El Salvador were the first to issue these certificates according to the WHO standards. And the idea is to be able to connect our countries. We are working a lot with vaccination certificates and health histories. But we also work on the local and country level. And it's important to emphasize that several countries express a strong interest in connecting the digital health with primary care. We've seen a strong work in this connection and this concept of connectivity and technological transformation in Brazil, in which in several states we have been working on this, like São Paulo, Paraíba, and others. And the idea is to conceptualize what is the digital transformation plan on the state level and then on the national level, to have entry points, for example, to use the digital transformation to align supply and demand on health. And I think that this is the same for all levels, the national, sub-regional, subnational, and local. But the goals are clear, the strategic partners are clear, and we are very excited because we see new opportunities to show quality services. Thank you very much. Thank you very much.
A Michele en el Banco Mundial y también agradecer a Jaime Saavedra porque con él y con Ferdinando Regalía también se organizó como parte de la alianza. Decidimos organizar una serie de webinars conjuntos, uno organizado por la OPS, otro organizado por el BIT, otro organizado por el Banco Mundial, pero siempre con los tres participando, ¿no? Me había olvidado de mencionarlo, Jaime, pero muchas gracias. Entonces, la pregunta ahora para Michele, ya en su nuevo regreso a esta posición en el Banco Mundial, como gerente de salud, nutrición y población para Latinoamérica y el Caribe. La pregunta es muy concreta. Desde la perspectiva del Banco Mundial, Michele, ¿cuáles son las líneas prioritarias del banco en salud digital para fortalecer las redes integradas de servicios de salud y cómo están pensando avanzar en la región?
Bueno, muchas gracias, Marcelo. Vuelvo a América Latina después de 3 años trabajando en el Medio Oriente y África del Norte. Y no hay manera más agradable de hacerlo que estar acá con ustedes en este evento de la Alianza de la Salud Primaria. Estaba con ustedes cuando se estaba lanzando, entonces realmente felicitaciones a todos que trabajaron también para llegar a este punto y más agradable que estar acá enfrente de la bahía de de Botafogo en Río de Janeiro. Voy a hablar en inglés, necesito un par de semanas más para acostumbrarme de vuelta al español. Bueno, in the World Bank, now working, speaking about the manager for health in Latin America, certainly our mission, our contribution to the sector is to work with countries to advance towards the universal health coverage. And we now know that this cannot happen without a good, successful digital transformation, as it contributes to improve access, quality, continuity of care, and also strengthens resilience in times of crisis. Then, as working in the World Bank, all sectors now have been asked explicitly to support creation of jobs beyond the specific sectoral mission. And in this context as well, both public and private investments in digital transformation and related policies are critical for jobs creation and will contribute to stronger economies and more sustainable budgets for health. Then, in this context, I would like to just mention 5 key lessons learned of working on digital health in LAC, but also globally, and it overlaps with some of what Sebastian and Javier have already said. But first, there is a need to shift from a simple mechanistic digitalization approach to a digital in health approach. Technology and data must be progressively but consistently integrated into health delivery and management models in a routinary way. They cannot just be parallel processes. The second is that digital health strategies are necessary but not sufficient. In LAC, at least 16 countries have developed national digital strategies, but implementation remains the big gap, and making progress requires strengthening capacities, predictable financing, and regular, precise, rigorous monitoring, among others. The third, and you mentioned governance, effective governance has to be balancing technology, processes, and clinical practices. You said that very well already, and most digital transformation processes do not fail because of technological flaws, but because the clinical processes are not adequately updated and the health personnel is resisting or is not able to adjust to the change. And therefore, strong governance, capacity building, and especially change management is absolutely central to successful digital transformation. Fourth, and this has already been said, political commitment and leadership have to be the anchor. And when authorities publicly support, prioritize resources, protect continuity, progress in digital transformation is faster, and without that, digital efforts remains fragmented and vulnerable to political changes and short-term budget cycles. And finally, just as a metaphor, digital transformation in health is more like a marathon than a sprint. It has to be steady, without rush, but without pause. It's something that we know is going to take time, is going to go, sometimes you need to have some sprints, but you cannot risk to accelerate so fast so that, you create resistance and pause and cool that momentum that is necessary to really keep a steady medium-term vision and implementation and pace.
Thank you. Muchas gracias, Michele.
Thank you, Mr. Michele. Got it. And now thinking about this, I would like to make the same question for all 3 of you. And it's a bit risky to imagine this because and I would also like to present this question to everyone here of our audience. We imagine that we are entering 2030. So this is a question for strategic thought and vision. And whatever you say here will be recorded for the future, and in 2030 we will be able to go back to this. What do you think we were able to reach in the Americas as a region? And let's see what the countries also have to say. Thanks to the work that each of the institution has carried out regarding digital transformation. So we'll start today. And what would you like to see due to all of this joint work and following the priorities of the countries in digital transformation by 2030? So let's begin with Mr. Michele. You can speak English, Spanish, Italian, whatever you wish. Well, it's not easy for me to speak Spanish, but for 2030, we would like for the digital transformation to have allowed us advance the region and develop the region, especially in three topics. On information, for the clinical information to flow between levels of care and in the government. The second is that primary care is strengthened through digital transformation and platforms. And the third is, as you mentioned, is that the decision makers use quality data and real information to improve access quality of healthcare services provided. Thank you very much. Thank you very much. The route is already designed for us because we're all in with the digital Pan-American route, and we have studies. And what are the case studies? What is the way that we can show that this works? And these case studies are, for example, the vaccination cards, or the history, the health history, or even the electronic prescription. You can imagine if you have a prescription from Brazil and you can go to the pharmacy in Paraguay and use it, and because there is a communication and connection between the countries. But I would also like to highlight that in addition to those case studies that will strengthen this Pan-American route, I would like to understand how citizens, how individuals can empower themselves and become the owners of their information and their health history. Supported by digital transformation, they are the ones who will give access to those who need to have access for the health providers, for example. So myself, as an empowered citizen, I can give my health provider access to such data, and maybe to another health provider some other access to other data, because I am the owner of my information. And this connection with this integrated health system with a quality service is what we want. And this is where empowered citizens may use and become vehicle to access their information is one of the most important dreams for 2030. Thank you very much.
Well, this is a complex question. But I have to see, as I'm the third one, I have to say that I'm absolutely in accordance of what has been said. When we are building this new space of strategic partnership, we agree that those are the results we hope for. And I hope we arrive there at 2030. I think that to measure the success of digital transformation will never be enough, seeing how much technology we have been using. We will see when we have a PHC that is really resulting in better health for the people, where everything is connected. This is what we want for in digital transformation, to be a building block in this agenda for healthcare. This implies interconnected primary healthcare. We must have also referrals where the patient doesn't get lost. navigating the system. The digital agenda is there to facilitate the patient's journey, and everything has to be integrated in the processes and in the models, especially in remote areas where people are more vulnerable. So we have to fill in some gaps or a series of gaps and then we will use the digital data, hard data that will enable us to make decisions, hard data about the differences or what are the problems of those people who live in remote areas. If we have bad data and data is not interconnected, they are not valuable for us. We need integration with AI. If we don't have quality data, AI is just a dream that will not be realized. They say that the algorithm of AI, if the data is garbage or rubbish, the result is rubbish too. So those are the elements that help us build a real agenda that will allow us to get to 2030 with a good result. AI will help us to accelerate this digital transformation. I would like to emphasize that the space for implementation of this agenda is the result of this agenda in 2030. In the landmark of this alliance, where we today are presenting the results that we have gotten, is the fact that we share information. The International Bank and the World Bank, the Inter-American Bank, and the World Bank, where we create a local space that is strong. We've shared agendas, we share decisions, and with a goal up to 2030. And we have, the result is not going to be just one, but it's going to be for everybody involved. Thank you very much. That would be the end. And I would like to say something, to add something. We have talked inside PAHO and also with my colleagues from IDB, how we can influence the educational area so that those themes is not that someone wants to take a course of something and digital health and technology is just like a complement. That's not what we're talking about. In the first 20 years of my career, I had the IT as my major. I was not Marcelo, I was the guy from IT. If something didn't work, they say, get the guy from IT, get the guy from IT. That was my name. Now people still say that I am the guy from IT because of the digital transformation. So in the case of Brazil, there is a vice ministry of digital health, but we have to learn from those models. If the countries are going in this direction, it means that digital transformation is a cultural change. It's not something complementary. I am from Argentina, but many countries have the same saying that each person should take care of his own business. If you think that in 80, instead of having money, you can have access to your medical chart, this would be, you can go anywhere in the world and I can take out my medical chart. And we are still discussing how get to interoperability, because many times we don't work in an interoperational way. We have to reinforce the interdisciplinary work so that everybody is on the same page. Everybody would have access to the same thing. I would like to have a hand of applause to my colleagues in the panel. We have learned a lot. And the next panel, I would like to stay here, but now I would like to give the floor to my colleague, who is going to be the moderator, and we are going to leave the stage. And let's have the next panel. Thank you. Thank you very much. And now the second panel, the countries and now the moderator is from the PAHO, Myrna Marti, Mrs. Myrna Marti. Now the Deputy Minister of Health of Panama, Mr. Zambrano. The Deputy Minister of Health from Dominican Republic, Mrs. Batista. From the Ministry of Health of Brazil, Audie Fischer. The Information and Digital Health Secretary from Brazil, Ana Stella Haddad. And the Chief of the Program of PAHO, Gabriel Itok. Good afternoon, everyone. Well, I'm going to copy what my colleague Marcelo Agostino said. I'm very thankful for having been invited to be to this panel and also to come to Brazil and to this wonderful city. It's a pleasure to be here. And also, I am in very good company with these panelists who represent a follow-up of the previous panel. We've heard with attention the perspectives, the projects, the mission, and the new views of other countries that are part of this alliance, and new perspectives and new visions that the countries are open for the fact that we can lead studies on these countries, and also collaboration amongst countries that are so much needed. So the idea of this second panel is to listen to the representatives of each different country, and you have the capacity to make the decisions, the clear ones, at the right time, so that the mandates of digital transformation are really enforced, so that we can say that we are going in the right direction. We know that this is a reality in many countries, this transformation, but we still have many gaps, mainly in the digital area. So this round of questions is going to be centered mainly in knowing a bit more about the experiences that countries such as Brazil, the Dominican Republic, and Panama, have had in the implementation of digital health to strengthen primary health care. And we have invited our friend Gabriel so that he can talk about one of the themes that appeared in other talks, that is human resources and how to train human resources in health. I would like to start with the first question to Ana Stella. She is the Secretary of Digital Health in Brazil. Brazil is one of the first countries in the world to have a ministry dedicated to health and information, or IT. How did you start this initiative, and how were you able to create this technological theme to be a central theme in something concrete like more access to experts and reducing the waiting time also for that? Good afternoon. Thank you very much, Mirna. Thank you for your question and for the opportunity. I would like to compliment all the other panelists, the representative from Panama, from the Dominican Republic, my colleague from Brazil, and the virtual field of health that we have been following for some time. Professor Campos is here, and I started in the Ministry of Health working in his team. And I think this is one of the first places where a Secretariat of Digital Information in Health was born, because it was born in the Ministry of Health, but coming from different places. And for the very first time, they were placed strategically in a shared way within a ministry. When I started in the ministry in 2005, Professor Campos was the Secretary of Work Management and Education in Health, and the Secretariat had been recently created. So the issue of health professionals as a centerpiece in the health system was just starting. There, I got to know experiences from universities with telehealth. So we had a challenge to strengthen primary health care. So he asked us, we have an experience in São Paulo, in Minas, let's map what else we have in Brazil. And your challenge is, can you put telehealth to qualify primary health care? So telehealth was not an assistance process, but really it was born in the area of qualification of health professionals. Then it was incorporated to the health system. Looking at data SUS, that is going to be 35 years, it's almost as old as SUS. It was born within DataPrev, that is a data processing system. And when SUS was created, we decided to create an information system. But DataSUS, that is our department of IT in SUS, has created more than 400 centers. So we have a heritage of historical series, data, also databases that were fragmented, and they were not very used for decision making. In 2011, in the Secretariat of the Ministry of Health, there was a department created of monitoring strategic information. In 2022, post-pandemic, in 2022, we had the presidential election and President Lula won the election. So he created a transition group to study the government in the area of health so that he could formulate his government. The health group had 4 ministers, previous ministers of health, Minister Padilha, Nisi also. They studied several themes, and Mr. Masuda, who is here, was in the group, and they concluded that it was very important to create this Secretariat of Health, Digital Health and Information. They were working isolated from one another, so it was decided that they should be integrated. So then we decided to go in this direction, that the IT area was only operational. We are still struggling with this view that data source is called only when people say, do this, do that, and the other. No, we have a strategic role. We have to understand all the process, all the journey of the patient. And based on that, we are going to design the digital part to support the healthcare. So digital health is interdisciplinary. There's no software engineering area, computing area, data area. Everything has to be integrated, and it is rather complex. But I think that the pandemic has brought an opportunity, because a need was created for us to advance in the digital area very quickly. And so now I know, and we all know, that IT is very important for the health system. Our area, digital health, is a strategic area.
Thank you very much, Anastela. And now we will continue with Brazil, with Mr. Andre Fischer, who is also from the Ministry of Health. Audrey, what I'm going to, I want to ask you to please tell us what is your role and your function, so that everyone can meet you properly. And what decisions regarding management and the concrete uses of digital tools do you consider that were key to integrate promotion, surveillance, and care, and also achieve real impact in the access and the continuity of care on the community level? Good afternoon. Good afternoon, everyone. I would like to greet our panel, and it's good to talk with after Anastela, because she already gave us a timeline, and I would like to talk about 2011, when Brazil made the decision to make the prescription, the medical chart, the digital medical chart, as a policy, and that those are data that are important when consolidated for the decision-making process. And so this fraction viewed according to the objective is very important. In 1975, for instance, we had a mortality system that brought some of the statistics that we used, and it comes from our oldest system. In 2011, we worked primary health with the SIAB, which is the primary health system. It worked in a consolidated way, so where the teams would inform the number of people registered and children, and that is how we brought the information that were related to the primary health teams in Brazil. In 2011, we began building the chart, and it was launched in 2013, and it has been adapted to reality a long time. So in 2015, we launched mobile solutions, so it could be used on your mobile phone, and we also came back to concepts that were mentioned earlier regarding the proactivity of the federal government, and with the focus on our territory and on interoperational solutions, because we have this concern regarding our tools so that we have a reduction of the time the health professional uses in informing different people. That is something that we have included in our systems. We have several solutions like notification, but that are still not totally integrated. So it's something that we've been advancing as a secretariat, but it's still a necessary change. Thank you, Audrey. And now my question goes to Yudelka Batista, Deputy Minister of Strengthening and Development of the Ministry of Public Health and Social Assistance from the Dominican Republic. Yudelka, your country has advanced sustainably in the analysis of data for health and counts on political decision that it has national reach now this year in 2026. What are the expected impacts from this process, and what were the main challenges you have identified now?
Okay, thank you. It is true that last year we were in El Salvador, where with the support of the IDB, we were able to do a diagnosis to identify the fragmentation and what are the steps we have to take, or that we know since last year, and that we, because of them, launched our route of transformation in the area of health. The concrete impact that we are trying to get at after all those years, after all the work of our board, and we want theory to be enforced in an operative way. It's not only a theoretical exercise, but it must be a space where we can demonstrate in a collaborative way and in a way that can be checked, that the systems of information about health in our country can exchange clinical data in a safe way, in an opportune way, and in a useful one. It shall be totally aligned with the national system that we have established in the last December. On the 15th, we had an event that was also supported by the Inter-American Bank, and it was a shared effort, and we hope to have also the support of our partners, PAHO and the World Bank. This effort is shared, and we want to have a more efficient. This effort is going to be centered on primary health care, because that's where we need more efficiency right now. Thank you. Now, the last question is Dr. Zambrano from Panama. Panama has a long tradition of digital health. For instance, we can highlight that very recently you have approved a National Commission of Digital Health. How did you position digital as a strategic tool to strengthen primary health care? How did you do that? Thank you very much. Once again, I would like to thank PAHO, the World Bank, and the IDB that have been supporting us so that everything really was put into work. And we use AI and the technology and all the tools that have come to stay. We have to understand this. Because if we don't use AI and technology, we are going to lag behind and all our goals will not be met. To Panama, the digital transformation is not the goal in itself, but it is a tool, a strategic tool to strengthen primary health care, to improve the access, the follow-up of the citizens, and also territorial equity. We start based on evidence, applying and analyzing digital transformation from PAHO that has allowed us to identify gaps in governance, interoperability, human resources, and the data use for decision making. This is fundamental. This is paramount because, as we say, if you don't have good information, we cannot make the right decisions. We would just be speculating. Based on this technical exercise, Panama has elaborated the national digital transformation in the health system 2025-2030, aligned with the priorities of the system, emphasizing the first level of attention. From its conception, the strategy puts primary attention or primary health care as the main beneficiary of digitalization, is strengthening the decision-making capacity of the first level, improving the references, and also linking networks of services that are fragmented without it. One of the first fronts of implementation was telemedicine as a concrete response to gaps of access in areas that are remote and where we don't have experts. We were able to attend more than 43,000 patients of chronic diseases in more than 14 regions of our country. So the coordinated action between the World Bank and PAHO, we avoided fragmented solutions and we ensured technical answers or responses. And besides telemedicine, we implemented electronic expedient called MediHeras. This is operating in 6 regions and it benefits more than 70,000 people. This tool permits that health teams can use digitally the use of medicine in remote areas, and we can synchronize the information electronically. And this makes it easier to have a follow-up with each citizen, because we have available to us clinical data in any place of medicine. We used AI also to detect breast cancer with ultrasound and mammography. Currently, we are introducing AI with scanners to using cytology to prevent colon cancer, and we want 0 deaths due to colon cancer in 2029. And we are reinforcing this so that we can meet the goal. Digital transformation, when it is articulated with primary healthcare, it becomes an accelerator of equity, efficiency, and resilience of the health system, more than a technological process. Thank you very much. Thank you, Manuel.
And now I have a question for Ranel Mistowski, responsible for the virtual campus of PAHO. I'll ask a composite question because we'll have a second round, and I'll make the same question for the rest of the speakers. So we'll have 2 questions in one. Based on what we've heard to now from the organizations and the countries, what are the main opportunities for training in digital transformation that is offered by the virtual campus of PAHO? And what critical competencies should be prioritized in order to strengthen primary care in this new digital context? This is the first. And giving continuity to the previous panel and Marcelo's question, if we were in 2030, what concrete impact do you experience as a knowledge with every country, and also to be able to be doing this in Brazil, because Brazil was the pioneer in the virtual campus, and as my colleague said, the virtual campus began by learning what today are the great educational virtual platforms in Brazil. And with regards to your question, Mirna, and the comments, I would like to highlight 2 or 3 issues. First, that since we've been everything we've said since the morning, behind all of this, we have people. We have our health workers, our health professionals, and the populations that we must reach. From the point of view of the virtual campus, we have a range of courses that we offer and that we've been working in cooperation with other departments of our organization. And I would highlight 2 or 3 main issues. One is very related to governance, interoperability, ethical issues regarding the use of digital health that are in the minds of managers and decision makers, and those that come to our courses from the point of view of management, of what I need for my country or my region, what I need for my network. That is a very important level and is focused, which the campus focuses on. But there's also a second level that also arrives with our users to the campus, which are the health professionals and health workers in our countries, since those working in hospitals or health centers in remote areas, rural areas, those that are very worried or very concerned to learn about the tools. How can I have a better consultation in telemedicine? What are the tools that I can count on? How can I collaborate with my work network to achieve better results? And here we see that the device must not be something that is far, but it must be something that helps me connect with people and work better and be meeting eye to eye with my patient and the community, even if remotely. Those are the two aspects I see, the manager's point of view and the health worker's point of view. And we see this both in our digital health courses and those courses that are focused on primary health care and mental health courses that are demanded by health professionals because they find here a tool to communicate better. They use these devices, ensuring the best delivery. I was thinking about the presentation that the mayor of Rio, the local government of Rio, talked about. They said they have a WhatsApp and a team and the professional, a physician that is available, and that is also appears as a demand in our service, in our quality service, and in our campus. And regarding your second question, if there is something that the virtual campus seeks, is to reach every health professional in the region through our virtual campus, working interoperationality or working with interoperationality with each platform so that training can reach those who need it in a timely manner. And it's also important to say that this training must respond to the transformation that the system needs, with the tools that the health system needs. And also this training must be recognized in the training and formation of this professional, even if they are small courses that are connected and create this formation for this professional. This is not a complement. It's part of the reality, the training reality for this health professional, and it must be recognized as such. So that is what I expect for 2030. Thank you.
And I would like to take the opportunity to acknowledge the fact that we have more than 5 million people involved in these health workers, and it's very important to offer the orientation to them. Now, I have a question to share with everybody, all the representatives from the different countries. We are going to start with Manuel. If we are projecting, let's say we are on the year 2030, what are the projects or initiatives that you are most proud of having implemented, and what is the result for the people? Let's say that today is 2030, and you have to tell us your impressions. Thank you very much. Today we are in the year 2030, and we would like to leave as a legacy the interoperability of all the systems, our clinical experience, our electronic prescriptions, our total coverage with experts in the remote areas of my country. This is critical. If we don't go to the remote areas of technology, it will be impossible to have a change in the levels of healthcare in those areas. We must have the tools to be able to cover these areas. AI, technology has come to stay, and AI is the tool to be used. It's not going to solve the problem. It's a tool that we are going to use to try and solve the problem of the experts that cannot be there. because this is a situation common to our countries. We see not only here but all over the world, even in the US. This happens not only in Europe also. They take our resources, our experts. This happens all over the world. How we are going to face that? I hope that by 2030 we'll be able to have solved all these problems with information that will help us to make the best decisions timely. This is fundamental. Very good, this question. It's a beautiful question, I would say. I'm most proud of the fact, and I have to confess that I talked with a teacher of technology. How do we see ourselves in the future? What would be our legacy? I think that having more systems, a robust infrastructure, and more systems, more robust infrastructures. But this is not enough if people don't have a better health. Without involving the well-being of the population, it's no use. We must implement a system that is interoperative in a vertical and a horizontal way. When I talk about networks, I'm not only talking about the public network, but also the private sector. I talk about electronic prescriptions, telemedicine, so that we can also be connected to the private sector. Our legacy would be that all our provinces that are very remote, where we have the most vulnerable population, could be covered by that system. If you detect a cardiovascular problem in a child via telemedicine, because we have connectivity, we can have a specialized appointment for that child with a pediatrician, a cardiologist. So the legacy would be the route to identify and implement 100% in the public sector and the private one too. Thank you.
I think that it is important to understand as a landmark and the consideration that we do not need just one tool, because when we have we work with not just one medical chart, but we have a system that organizes all the information so that it can be used. This brings a very important formative landmark to understanding the health system in the country. Today, our health data system gathers information not only from the public sector but also from the private sector, so we are able to use all the available data by the insurance, and this notification doesn't come only from one tool, because we are a continental country with different realities. That is why we need this common communication that strengthens the health system and allows us to have this scenario in which we are working, where people are building this care, can be respected in their diversity. And that is a very important landmark that we'll leave as a legacy. Well, I think that all our speakers brought very important elements that compose the central agenda for digital transformation. I think that in our first panel, this was also very well addressed by all the organizations, and Dr. Sebastian Saizes brought us a roadmap from PAHO in their intelligence and evidence department. They have been building very solid documentation and very important documents for countries to follow the path is very clear. And I want to make a small analogy when Dr. Gabriel talks about the virtual campus for public health. That is very important for the training and courses and permanent education. That also, when we're talking about digital transformation, it is also a very important component, the training of people, the digital literacy, and not only to know how to use the tools, but also in their critical thinking and analyzing to create solutions with critical analysis in favor of what we want to produce and transform. And I watched this transformation in the permanent education sector, and I make this analogy because the virtual campus that reached 5 million enrollments, and this morning we spoke about UNASUS, which is our open university for SUS, also for permanent education and large scale using these technologies for training, that has reached 13 million enrollments. And this was a turning point. This is a change in the parenting, because it's not only to do more, but to do differently, as the virtual campus has done, as UNASUS has done, and is already and continues to do here in Brazil. If we hadn't had all these protocols and everything during the pandemic, wouldn't be possible if UNASUS wasn't ready to offer what was important at that moment. And that is, was a turning point for us. And regarding the digital transformation, there's a very important component that wasn't mentioned here now, but was mentioned before, and we have the president of our health council, Dr. Fernanda Magano, is for us to build this process focusing on the user and social control. When I went to the council, I mentioned this. The questions that I received, I saw that the council was really in alignment with this agenda. They created a thematic board for this, and they had the right issues like data protection. And the issue I wanted to bring for the 2030 agenda was digital sovereignty. That more than anything, when we're talking about interpersonality and electronic charts and data in health and integrating public and private data, it is very important that this is built on solid basis. Where are this data? What is the governance that we are working with? What is the e-government strategy? Where's our cybersecurity actions? And today, as the government, and we are collaborating for all of these actions, digital transformation is a movement that is not only for the health area, for SUS. We have a digital strategy in the government. We have a data protection area in the federal government, also specifically for health, and the cybersecurity actions. It's not an easy road. We know we live within a digital transformation in which big techs are manipulating and guiding the way. But in health, we must, and I believe that SUS brings us very good principles and guidelines for us to do things differently. So my 2030 agenda would be for us to be able to implement and protect digital sovereignty.
Thank you very much for all your very sincere and honest answers. And as a final comment, I would like to say a few words that appeared in all the discourses, the previous one and this one. Resilience, not to abandon the time that we dedicate to healthcare, to know the context and to have in mind the diagnosis, to listen to the demands of the health personnel, because they want to improve and they want to know how to get to people in an easier way so that we can have a better governance that everybody is aiming at, and also the political interest. Because this has been also a driving force for these teams. We have been talking about this political will for many, many years. So it's good to be able to see the results. It's a result of a long struggle and lots of work. And we are going to be very pleased to have heard during the all day long that the digital transformation is part of all the interventions from all countries. It's not only an individual satisfaction, but a collective satisfaction that we know this is the way to go, because we know that transformation is not arrived at in solitude. It has to be shared. The organizations that drive this transformation, the health professionals that want to see the transformation, and also the governments. Let's have a hand of applause to this panel, and thank you very much. That's the end of it. Thank you. Ladies and gentlemen, thank you very much to be here today. And we have finished. We are wrapping up. We hope to see you tomorrow at 8:30 for the second day of the event. Thank you very much to all of those who are following us via the internet. Thank you. Have a good evening.
Señoras, ay. ¿Algún micrófono ahí, si no?
Som. Oi. Oi, oi. Alô, alô.
É, não, já desligaram, fechou lá.
Alô, alô.